What if the basic rules of pharmacology aren't as complicated as they first appear? Why do medicines with the same ingredient act differently in different people? And if one small change in absorption or metabolism alters the effect, how much control do we really have over a treatment? Welcome to Rest Academy. Tonight, in 22 Calm Steps, we'll uncover the foundations of pharmacology, how medicines move through the body, how receptors shape their action, and how safety margins guide their use. But here's the deeper question. If your body itself transforms every medicine you take, then isn't understanding pharmacology the only way to see clearly what's really happening inside you? Because these ideas are heavy to hold, I've prepared a free practical guide. You'll find it in the description, like a map you can return to whenever you need it. So take a slow breath. Tonight we begin with the first truth, speaking the same language of medicine. You picture a quiet library at dusk, shelves in long rows, each book labeled, cataloged, and placed with care. Pharmacology needs the same order. When you and a colleague say the same name, you should imagine the same compound, the same family, and the same expected effects. Shared language is your first safety device. Start with names. A generic name is the non-proprietary identifier assigned to a medicine. It is the stable label that persists after brands change. A trade name is the brand chosen by a manufacturer. It varies across markets and time. A chemical name precisely describes structure, but it usually stays in the background, like a book's ISBN, exact, necessary for inventory, rarely spoken aloud. You keep the generic name as your common tongue. You recognize the trade name to connect with packaging and patient memory. You respect the chemical name for unambiguous identity when details matter. Next, the class. A drug class groups medicines by shared mechanisms or dominant effects, the way shelves group books by subject. Class tells you likely benefits and common cautions without memorizing every title. Analgesics reduce pain, antibacterials suppress bacterial growth or survival, bronchodilators widen airways within each shelf, subshelves refine the picture, beta-2 agonists under bronchodilators for example. Class is predictive but not perfect. Drugs can sit across adjacent shelves because tissues, enzymes, and receptors overlap. Mechanism of action is the how of a medicine. A mechanism describes the key interaction, binding a receptor, inhibiting an enzyme, opening an ion channel that leads to downstream physiological changes. You think in causal chains. A molecule occupies a receptor, the cell changes its signaling, an organ alters its function, a symptom shifts. When you anchor to mechanism, you can anticipate both intended effects and common side effects because the same pathway rarely confines itself to one tissue. Indications tell you the when and why. An indication is a clinical situation in which expected benefit outweighs expected harm under a defined scope of practice. You avoid drifting from indications just because a mechanism seems helpful. Scope and supervision exist to protect patients and providers. You also meet off-label use in broader practice, but you separate that concept from your role and protocols, keeping boundaries intact. Contraindications mark circumstances when expected harm outweighs benefit. You often see two flavors. An absolute contraindication is a stop sign because harm is very likely and serious. A relative contraindication notes conditions that elevate risk. In those, a well-supported benefit under oversight may still justify use. You evaluate the situation, not just the list, because context, comorbid disease, concurrent medicines, current physiology shifts risk. Dose is the quantitative amount administered. For this course, you will treat it conceptually rather than numerically. Instead of memorizing numbers, you focus on principles. Start with established supervised ranges, consider patient-specific factors such as age, organ function, and route, and recognize that more is not always better. Many effects plateau, while adverse effects continue to rise. Dose lives alongside concentration, which is what tissues experience. Route and metabolism help translate one to the other. Onset is how quickly an effect becomes noticeable. Duration is how long it persists. An inhaled compound can act in moments because the lung offers vast surface area and direct access to circulation. An oral tablet can take longer because it must dissolve, survive the gut, and pass through the liver before reaching systemic tissues. duration depends on distribution into tissues, chemical modification by enzymes, and elimination through kidneys or bile. You expect a mismatch between a medicine's presence in blood and its clinical effect if it binds tightly to receptors or triggers long-lived signaling. Side effects are foreseeable effects tied to mechanism but not the primary goal. Adverse reactions are harmful and undesired effects. Some are predictable from mechanism, dose-related, while others are idiosyncratic or mediated by the immune system. Allergy refers to an immune-driven response, often reproducible, sometimes escalating with re-exposure, distinct from predictable pharmacologic effects such as mild tremor or flushing. Clear words help you document what you see and communicate risk accurately. Routes of administration are the paths into the body: oral through the gastrointestinal tract, sublingual under the tongue via mucosa, buccal between gum and cheek, intranasal across nasal mucosa, inhaled into the airways, intramuscular into muscle, subcutaneous into the fatty layer, intravenous directly into the circulation, intraosseous via bone marrow channels. Each route trades speed, reliability, and convenience. Mucosal surfaces offer rapid entry without needles. Oral routes are simple but limited by digestion and first-pass metabolism. Parenteral routes bypass barriers but demand technique and sterile care. You also note two pharmacokinetic ideas that will recur. Bioavailability is the fraction of a dose that reaches systemic circulation intact. First-pass effect is the hepatic transformation that can reduce bioavailability after gut absorption. Together they explain why the same medicine acts differently when swallowed versus placed under the tongue, or why inhaled particles sized for bronchioles can relieve breathlessness faster than an oral tablet of the same compound. Consider a brief clinical moment. A middle-aged person describes central chest pressure that radiates to the left arm and began at rest. They are pale and slightly clammy. Your language keeps you steady. You translate the complaint to a possible cardiac indication, recall mechanisms that might alter clot behavior or vessel tone, and remember contraindications that could worsen perfusion. You do not diagnose or treat in this course, and you do not share or use dosing. You simply recognize patterns and invite prompt professional evaluation, especially if pain is severe, associated with shortness of breath, fainting, or new neurological symptoms. Hold the library image a little longer. Names keep you oriented to the right book, class gets you to the right shelf, mechanism tells you why the story unfolds as it does. Indications and contraindications decide when to take the book down. With those labels aligned, every later aisle becomes easier to navigate. As the stacks settle into order, one question remains. Once a medicine enters the body, by what steps does it travel from entry to effect, and finally to exit, and where do the real bottlenecks hide? You imagine a river at night. A drop enters upstream, drifts through channels, passes gates, pools and backwaters, and finally exits to the sea. A medicine follows a similar course through you. 4 linked steps, often abbreviated as ADME: absorption, distribution, metabolism, and excretion. Each segment sets the tempo for effect. Absorption is the step from the site of administration into the bloodstream. Across skin, gut, lung, or mucosa, a molecule faces membranes made of lipid, lipophilic, fat-loving compounds. Slip more easily through these barriers. Hydrophilic, water-loving ones use pores or transporters or wait for pericellular gaps. Surface area and perfusion matter. Alveoli present a wide, thin interface with rich blood flow, so inhaled molecules often show rapid onset. The stomach has acid and limited area, while the small intestine offers long villi and dense capillaries. Gastric emptying time shifts the handoff between stomach and intestine. A slow stomach keeps a dose upstream. pH partitions weak acids and bases into charged and uncharged forms. The uncharged form typically crosses membranes more readily, so local acidity can tilt absorption without changing the underlying chemistry. You also consider first-pass effect, the share of drug removed by gut wall and liver before reaching systemic circulation. A swallowed tablet may see a high first-pass extraction. A sublingual tablet often bypasses this early loss. Bioavailability is the fraction of an administered dose that reaches systemic blood unchanged. By concept, intravenous delivery is complete bioavailability. Other routes vary. Reduced bioavailability can result from poor dissolution, degradation in the gut, active efflux back into the lumen, for example by the transporter P-glycoprotein. metabolism and enterocytes or hepatic extraction, formulation and route are levers. That is why the same compound placed under the tongue can act more quickly and predictably than when swallowed. Distribution describes how the drug leaves blood and partitions into tissues. Blood flow sets the order of exposure. Vessel-rich organs such as brain, heart, and kidneys see compounds first. Skin and fat see them later. Capillary structure matters. Fenestrated capillaries in liver and glomerulus are more permissive than tight junctions in the brain. The blood-brain barrier layers endothelial tight junctions, transporters, and glia. Only molecules with sufficient lipophilicity or specific carriers cross effectively. Protein binding in plasma, often to albumin or alpha-1 acid glycoprotein, holds a portion of drug in a reversible reserve. Only unbound molecules cross membranes and interact with receptors. A concept called apparent volume of distribution summarizes how extensively a drug leaves the vascular space. A small volume suggests confinement to plasma and interstitial fluid. A large volume implies deep partitioning into tissues or fat. These patterns explain why two medicines with similar doses can display very different concentrations at their sites of action. Metabolism is chemical transformation by enzymes that generally increases water solubility and prepares the molecule for excretion. The liver is the major site, though gut wall, kidney, lung, and blood also contribute. You often hear of Phase 1 and Phase 2. Phase 1 introduces or exposes functional groups, oxidation, reduction, or hydrolysis, commonly through cytochrome P450 enzymes. This can inactivate a drug, activate a prodrug, or create intermediate forms. Phase 2 conjugates attach polar groups such as glucuronic acid, sulfate, or acetyl groups, which typically enhance elimination. Enzyme systems show variability across people due to genetics, age, disease, diet, and other medicines. An inhibitor can slow the clearance of a substrate and raise its levels. An inducer can speed clearance and lower levels. These interactions are why grapefruit, a source of intestinal CYP3A, and transporter inhibition can change exposure for susceptible compounds without any change in dose. Excretion is removal from the body. Kidneys filter, secrete, and reabsorb molecules based on size, charge, protein binding, and transporter activity. A drug that is freely filtered and not reabsorbed is cleared in step with glomerular filtration. Active secretion can exceed this rate. Strong reabsorption can reduce it markedly. Biliary excretion delivers drug or metabolites into bile for elimination in feces. Some conjugated drugs undergo enterohepatic cycling when intestinal bacteria remove conjugates and allow reabsorption, creating a second smaller wave of exposure. Lungs exhale volatile agents. Sweat and saliva contribute minor routes. Two linked measures synthesize these processes: clearance and half-life. Clearance is the apparent volume of plasma from which drug is removed per unit time. It aggregates metabolism and excretion. Half-life is the time for concentration to fall by half when elimination follows first-order kinetics. It emerges from the relationship between clearance and distribution. While you avoid numbers here, you keep the relationships. Greater clearance shortens half-life. Broader distribution often lengthens it. A short half-life aligns with quick offset. A long one sustains effect after input stops, especially when deep tissue compartments slowly return drug to blood. Transporters shape each step, much like sluice gates in the river. P-glycoprotein in gut and brain can push drug back into lumen or blood, limiting entry to systemic circulation or central nervous tissue. Organic anion and cation transporters in kidney move drugs into urine against concentration gradients, enhancing elimination. When two medicines share a transporter, they can compete. When a third agent inhibits that transporter, both can accumulate. Enzymes and transporters often coordinate. A drug that induces both can markedly lower a co-administered substrate's levels, while an inhibitor of both can markedly raise them. Physiological states move the riverbanks. In pregnancy, increased plasma volume and altered protein levels change distribution. Increased renal blood flow can enhance clearance of some drugs. In neonates, metabolic pathways and transport systems remain immature. Distribution skews toward water compartments. In older adults, reduced hepatic blood flow, changes in enzyme capacity, decreased renal filtration, and increased fat proportion shift clearance and distribution. The same nominal exposure may produce stronger or longer effects. Liver disease can reduce first-pass extraction, raising bioavailability for high-extraction drugs. Kidney impairment can reduce elimination and promote accumulation of unchanged drug or active metabolites. Formulation directs currents. Particle size in inhalers affects where drug deposits. Larger particles impact oropharynx, smaller reach bronchioles. Enteric coatings protect acid labella drugs until the intestine. Extended release matrices slow dissolution to flatten peaks and extend exposure. Crushing them can dismantle the mechanism, causing unintended rapid absorption. Solutions, suspensions, and emulsions offer different stability and absorption profiles. Light, heat, and time can degrade sensitive compounds. A discolored or precipitated preparation signals altered composition and uncertain exposure. A brief clinical moment clarifies why this map matters. A person with chronic liver disease notices unusual sleepiness after starting a new medicine that normally causes only mild drowsiness. Reduced first-pass metabolism, increased bioavailability, reduced clearance, extended exposure, protein binding changed with low albumin, without touching dosing, altered physiology, intensified effect. Because abrupt confusion, severe sedation, new jaundice, or unusual bleeding can signal serious deterioration. Professional evaluation is urgent if such features appear. Your reflection is simple. When you picture a drug as a quiet traveler and the body as a branching river, you look upstream for barriers and downstream for exits. Most mysteries dissolve when you find the narrowest gate. You listen to the water settle. The molecule has entered, spread, transformed, and departed. Yet the effect you observe still depends on what happens at its landing site. Once a molecule meets its receptor, how does that contact become a signal, and why do some contacts activate while others silently block? Imagine a row of gates, each one marked with a different path into the body. A tablet on the tongue, a mist into the lungs, a needle slipping into muscle. These are not just variations of entry, but distinct strategies with consequences for timing and effect. Routes of administration matter because they shape how a molecule travels, where it first meets enzymes, and how quickly it can reach its site of action. The oral route is familiar to you. Swallowing a capsule means that the substance must pass through the digestive system, then through the liver before it enters circulation. This first-pass metabolism can dramatically reduce the fraction that actually reaches tissues, a phenomenon that explains why oral bioavailability is often lower than other routes. By contrast, the sublingual route, placing a tablet beneath the tongue, bypasses digestion and allows rapid absorption through mucous membranes. The difference between swallowing and holding under the tongue is subtle in behavior, yet profound in pharmacology. Inhalation presents another model. When you breathe in an aerosolized drug, the alveoli provide a surface area as vast as a tennis court, lined with a thin membrane and rich capillary beds. The gas or fine mist can diffuse into blood within seconds. This explains why agents like anesthetic vapors or bronchodilators can take effect quickly without the long delay associated with oral ingestion. Injection routes create even sharper contrasts. Intramuscular administration deposits medication deep within the muscle fibers, where abundant blood supply permits gradual uptake. Subcutaneous injection, sitting just under the skin, releases drug more slowly. Intravenous administration bypasses barriers altogether, delivering directly into circulation, which ensures immediate and complete bioavailability. With intravenous delivery, the plasma concentration curve rises sharply, a detail critical in emergencies. Each path involves unique risks. Consider the intranasal route, where sprays like naloxone enter through the vascular mucosa of the nose. The onset is rapid, but irritation and variability of absorption are possible if congestion is present. Or think of transdermal patches, where the drug seeps across skin barriers slowly, creating sustained release, but risking accumulation if not monitored. Picture a young emergency worker encountering a patient with difficulty breathing. The inhaler in the kit must be distinguished from a pill or an injection. Giving the right drug through the wrong route could mean no therapeutic effect at all. If uncertainty arises, professional guidance is essential, especially when airways are compromised or circulation is unstable. The reflection here is simple. You often underestimate how geography inside the body dictates pharmacological reality. The route chosen is as important as the substance itself. You may now wonder, once a drug enters the body, how does it move and distribute through tissues with such precision, sometimes favoring fat, sometimes water, sometimes a barrier like the brains? You picture a key turning in a lock. The key may open the door, block the slot, or turn halfway and hold it ajar. Receptors work in a similar way. They are molecular structures on or within cells that recognize signals, and the drug that binds them can be an opener, a blocker, or something in between. A receptor is typically a protein embedded in a cell membrane or floating inside the cytoplasm. When a drug or natural ligand binds, the receptor changes shape, and that change begins a cascade. Ions flow, enzymes switch on, genes express. This is the molecular translation of chemistry into physiology. Agonists are keys that open the door fully. They bind to a receptor and trigger the same effect as the body's natural messenger. Morphine at the mu-opioid receptor, albuterol at the beta-2 receptor. Both illustrate agonism, though their downstream consequences differ vastly. Partial agonists turn the lock only partway, producing a smaller effect even if all receptors are occupied. This can be useful when you want stimulation, but with a built-in ceiling, such as reducing risk of respiratory depression. Antagonists occupy the lock but do not turn it. They prevent other keys from entering. Naloxone at the opioid receptor is a clear example. By sitting tightly in place, it blocks opioids from activating the receptor and reverses their effects. Some antagonists are competitive, displaced if more agonist is present. Others bind in ways that cannot be overcome simply by increasing concentration, effectively silencing the receptor until new proteins are made. Inverse agonists take a subtler role. At receptors that display baseline activity even without a ligand, they reduce that spontaneous activity, pushing the system below its usual level. This is less common, but illustrates how drugs can sculpt receptor function, not only upward or blocked, but downward. Efficacy and potency are linked yet distinct. Efficacy is the maximal effect a drug can produce, how fully it can open the door. Potency is how much drug is needed to reach that effect, the efficiency of the key. On a graph, two drugs may reach the same plateau of efficacy, but the one requiring less concentration is considered more potent. This distinction prevents confusion when comparing compounds. A highly potent drug is not necessarily the more effective one. It may simply need less to reach its limit. Spare receptors deepen the picture. In some tissues, not every receptor needs to be activated to achieve the maximal effect. This reserve capacity makes the system more sensitive to agonists and more resistant to antagonists. Clinically, it explains why small amounts of a drug can still produce strong effects and why blocking a fraction of receptors may not reduce response as expected. Consider a vignette. A patient with wheezing receives a beta-2 agonist inhaler. Within minutes, airway smooth muscle relaxes and airflow improves. But if the same person also took a non-selective beta blocker for blood pressure, those drugs would compete at the receptor, and the expected relief could vanish. If breathing remains labored despite usual measures, professional evaluation is urgent, especially if lips turn blue, speech becomes difficult, or consciousness falters. Your reflection is quiet, the lock and key image is simple, but the reality is layered: full turns, partial turns, blocked locks, even reversed motions, each shaping the symphony of pharmacology. Now you wonder, when you compare two drugs on paper, how can curves on a graph reveal these differences in potency and efficacy without needing equations? Picture two hills rising on a plain. One is tall but narrow, the other broad and flat. Both represent a drug's effect as its concentration increases, and the differences between them reveal potency and efficacy without mathematics. On the horizontal axis of a dose-response curve, concentration increases. On the vertical axis, effect is plotted as a percentage of the maximum achievable. A curve that reaches a higher plateau demonstrates greater efficacy. It shows that the drug can produce a stronger overall effect when all receptors are engaged. A curve shifted leftward indicates greater potency. Less concentration is needed to reach the same effect. These visual cues let you compare drugs qualitatively. Imagine albuterol and epinephrine at airway receptors. Both can dilate bronchioles, but epinephrine activates multiple receptor families, producing a broad physiological storm. Albuterol, more selective, targets beta-2 receptors, focusing its effect on a graph. Their maximal efficacies may be similar in the lungs, but albuterol's potency appears higher because it needs less exposure at that site to achieve comparable relief. You also see partial agonists in these curves. Their plateau never rises to the full height of a strong agonist, no matter how much is given. Buprenorphine at opioid receptors illustrates this. It binds tightly and produces analgesia, but its efficacy is capped. That cap protects against some adverse outcomes, but also limits relief for severe pain. The graph encodes this ceiling. Antagonists reshape the landscape differently. A competitive antagonist shifts the agonist's curve rightward. You need more agonists to reach the same effect, but the maximal plateau is unchanged. A non-competitive antagonist lowers the plateau itself, reducing efficacy regardless of concentration. By studying the curve, you infer whether an antagonist merely competes for access or alters the receptor system in a deeper way. The therapeutic window can also be visualized this way. One curve shows desired effect, another shows toxic effect. Where they overlap too closely, the margin of safety narrows. A drug with a wide gap between curves feels forgiving. One with a narrow gap demands vigilance. This qualitative picture replaces memorized numbers with intuition. Steep rise and close overlap warn of risk. Now think of variability. Two people given the same drug may display slightly different curves because of receptor density, genetic variance, or coexisting disease. For instance, reduced kidney clearance can flatten or prolong the curve for a water-soluble drug, lengthening its action. The same graph that looks clean in a textbook bends subtly in real patients. In practice, imagine a patient taking multiple medicines. One drug may inhibit the enzyme that clears another, shifting its curve leftward. Suddenly, a dose that was once moderate now produces stronger effects. If confusion, dizziness, or fainting follow a new medication, the interaction deserves urgent professional review rather than adjustment on your own. Your reflection is brief. Curves are like silhouettes of drugs. Each shape tells a story of how much, how strong, and how safe. Learning to read them is like learning to read a landscape by its shadows. Now a new question rises. Once curves define potency and efficacy, how do you weigh benefit against risk, and what happens when the safe window is narrower than expected? Picture a narrow bridge across a river. On one side lies benefit, on the other side risk. The width of the bridge is your margin of safety, the therapeutic window. A broad bridge feels steady and secure. A narrow bridge demands caution with every step. Therapeutic window is the span between the lowest effective concentration and the lowest concentration at which significant harm appears. Drugs with a wide window can vary somewhat without major danger. Those with a narrow window require close supervision. The concept is qualitative. It reminds you that safety is not absolute but relative to how close benefit and harm sit together. Take anticoagulants as an example. They prevent harmful clots, but too much activity can trigger bleeding. The benefit is life-saving, yet the risk is also serious. By contrast, an over-the-counter pain reliever may have a broader window. Effective relief occurs well before toxicity becomes likely. Still, even familiar medicines can shift if liver or kidney function changes, effectively narrowing the bridge. Several factors constrict or widen this window. Genetics can influence how quickly a drug is metabolized. A fast metabolizer may need more to achieve benefit, while a slow metabolizer may drift into toxicity with ordinary exposure. Age alters clearance, as infants lack mature enzyme systems, and older adults may have reduced renal function. Disease states change the frame as well. Heart failure can reduce delivery of drugs to liver or kidney, slowing clearance. Even diet matters. Certain foods or supplements can inhibit or induce metabolic enzymes, quietly moving the line between safe and unsafe. Monitoring often focuses on drugs with narrow windows. Repeated blood tests for levels, or careful observation for clinical signs, provide a safety net. For example, medicines affecting the thyroid or certain anti-seizure drugs may demand routine checks. This is not about memorizing numbers, but recognizing categories. If a drug is known for a narrow therapeutic index, professional guidance and regular review are non-negotiable. A patient vignette illustrates the stakes. Someone stabilized on a narrow window drug suddenly starts a new herbal supplement. Within days, they develop unusual bruising and lightheadedness. The supplement inhibited clearance, raising active levels. Here, the bridge shrank without warning, and early medical attention was crucial. If you or someone you know ever experiences unexpected bleeding, confusion, or rapid swelling after starting or changing medicines, immediate professional care is warranted. Your reflection lingers. You understand why clinicians respect these narrow bridges. Crossing them requires balance, vigilance, and humility. And now the next question forms. If benefit and risk depend so much on balance, how does the nervous system itself tilt the scale, and why does stimulating one branch often suppress the other? Imagine two levers on opposite sides of a control board. Pull one, the heart races and pupils widen. Pull the other, the pulse slows and digestion resumes. These paired levers represent the autonomic nervous system, divided into sympathetic and parasympathetic branches, each balancing the other across organs. The sympathetic branch prepares you for exertion. Preganglionic fibers arise from the thoracic and lumbar spinal cord, synapse and ganglia close to the cord, and release neurotransmitters that set peripheral neurons in motion. The main messenger at target organs is norepinephrine, which binds to alpha and beta adrenergic receptors. Activation raises heart rate, dilates bronchioles, diverts blood toward muscle, and constricts certain vessels to preserve pressure. It is the fight or flight state, orchestrated by widespread adrenergic signaling. The parasympathetic branch restores calm. Preganglionic fibers emerge from brainstem nuclei and sacral spinal cord, often traveling long distances before synapsing near their target organs. Their main messenger is acetylcholine, acting on muscarinic receptors. Activation slows the heart, enhances salivation, stimulates gut motility, and narrows the pupil. It is the rest and digest state, tuned toward conservation and repair. These two systems rarely act in isolation. In the eye, sympathetic activation dilates the pupil through radial muscles, while parasympathetic activation constricts it through circular muscles. In the heart, sympathetic input accelerates rate and force, while parasympathetic input slows rate through the vagus nerve. At any moment, the net effect is the balance of both levers rather than one alone. Receptor subtypes refine the responses. Alpha-1 receptors constrict vascular smooth muscle, raising resistance and pressure. Alpha-2 receptors, often presynaptic, decrease norepinephrine release, creating feedback inhibition. Beta-1 receptors increase heart rate and contractility. Beta-2 receptors relax bronchial and some vascular smooth muscle. Muscarinic receptors diversify further, with M2 slowing the heart and M3 stimulating glandular secretion and smooth muscle contraction. The distribution of these receptors explains why selective drugs can target one organ system while sparing others. Drugs that mimic sympathetic signaling are called sympathomimetics. Epinephrine is broad, stimulating alpha and beta receptors alike, useful in emergencies like anaphylaxis. Albuterol is more selective for beta-2, favoring bronchodilation. Conversely, beta blockers antagonize sympathetic input at the heart, lowering rate and workload. Parasympathomimetic drugs, such as pilocarpine, enhance acetylcholine effects, while antimuscarinics like atropine block them, raising heart rate or dilating pupils. A patient vignette highlights this balance. A person with asthma takes a non-selective beta blocker for hypertension. When wheezing begins, the beta blocker hinders the action of inhaled albuterol, preventing effective bronchodilation. In this case, the tug-of-war between branches becomes a clinical hazard. If breathing difficulty persists despite usual treatment, professional evaluation is urgent, especially if speech or consciousness is compromised. Your reflection is calm. The body carries two sets of reins, sympathetic and parasympathetic, and health lies in how they pull against one another. The question that follows is natural. If sympathetic signals can open the airways, how does a single class of drugs use that pathway to restore breath in obstructive lung disease? You imagine two narrow tubes that should let air pass freely, yet swelling and constriction squeeze them tight. A medicine arrives, touches smooth muscle cells, and suddenly the tubes widen. This is the work of beta-2 agonists. Beta-2 receptors are a subtype of adrenergic receptors, located on bronchial smooth muscle and certain vascular beds. When activated, they trigger a signaling cascade, The receptor couples to a GS protein which activates adenylate cyclase, raising cyclic AMP. This second messenger activates protein kinase A, which phosphorylates targets that lower intracellular calcium. With calcium reduced, smooth muscle fibers relax, widening the airway lumen. The result is bronchodilation, restoring airflow to narrowed passages. Selectivity matters. Epinephrine activates beta-1 receptors in the heart, as well as beta-2 in the lungs, producing broad sympathetic effects. Albuterol, in contrast, is more selective for beta-2, allowing bronchodilation without the same degree of cardiac stimulation. Yet no drug is perfectly selective. At higher concentrations, even beta-2 agonists may spill into beta-1 receptors, producing side effects such as tremor, palpitations, or anxiety. Duration also varies. Short-acting beta-2 agonists like albuterol provide rapid relief of acute bronchospasm, while long-acting agents maintain airway relaxation over hours. The distinction reflects differences in receptor binding affinity, lipid solubility, and formulation. Clinical protocols distinguish between rescue and maintenance, but the underlying science is that binding kinetics shape how long receptors remain occupied. Tolerance can develop with repeated use. Continuous stimulation leads receptors to downregulate, cells reduce receptor numbers or responsiveness to restore balance. This adaptation explains why frequent dosing can reduce effectiveness. It also highlights the importance of using these agents as intended, under supervision, rather than escalating independently when symptoms persist. Picture a case: a person with chronic obstructive pulmonary disease uses an inhaler several times daily. One evening, despite repeated use, they remain breathless and begin to feel dizzy. Receptors may be desensitized, or the exacerbation may exceed the inhaler's capacity. Professional evaluation is critical in this situation, especially if breathing difficulty is accompanied by cyanosis, confusion, or exhaustion. You reflect quietly. A simple breath becomes precious when tubes narrow, and one receptor subtype, when gently opened, can give it back. Now curiosity shifts. If airways can be reopened by relaxing smooth muscle, how can blocking a single enzyme in platelets prevent clots from growing? And what hidden timing makes that intervention so powerful? You picture a river carrying small rafts that cluster together when they meet. These rafts are platelets, fragments of cells that float in blood and seal leaks by sticking to one another. If their gathering becomes too aggressive, the cluster can block flow, forming a clot inside an artery. A single enzyme within platelets helps regulate this gathering, and blocking it changes the whole scene. The enzyme is cyclooxygenase, often abbreviated CO-COX. In platelets, CO-COX converts arachidonic acid into thromboxane A2, a chemical signal that encourages platelets to stick together and constrict nearby vessels. When a drug like aspirin irreversibly inhibits platelet CO-COX, thromboxane production falls and platelets lose much of their ability to aggregate. Because platelets lack a nucleus, they cannot synthesize new enzyme. The effect persists for the lifespan of the platelet, typically several days. This makes timing important. The impact of one dose can last well beyond the presence of the drug itself in plasma. The consequence is a shift in balance. Blood still clots when necessary, other pathways remain intact, but the tendency for clots to grow larger inside coronary arteries is reduced. This mechanism explains why aspirin is often used in the context of suspected heart attack. It can slow the expansion of a clot that threatens to block a coronary vessel. Yet platelet inhibition comes with a cost. The same mechanism that reduces harmful clots also increases bleeding risk. A cut may ooze longer, a bruise may form more easily. The therapeutic window here is shaped by timing and context. During an evolving clot in the heart, the benefit outweighs the risk. In someone with active bleeding or recent surgery, the balance tips the other way. Think of a patient who develops chest discomfort while gardening. Pale, sweating, and clutching their chest, they are offered aspirin by a bystander, who recalls hearing it helps in heart attacks. The act may buy time until emergency services arrive, slowing clot growth. But imagine another patient who has just undergone abdominal surgery. In that case, taking aspirin could worsen bleeding at the surgical site. This duality illustrates why indication and contraindication must be weighed carefully. If chest pain is severe, prolonged, or associated with shortness of breath or fainting, urgent professional care is essential, regardless of self-administered measures. Your reflection is steady. One small enzyme inside tiny cell fragments can decide between flow and blockage. Controlling it shapes life's most vital current. Now the next question arises. If a drug can block platelet signals, what happens when a medicine instead competes for opioid receptors, displacing powerful narcotics and reversing their grip on breathing? You imagine a crowded harbor where many boats compete for limited docks. Each dock represents an opioid receptor in the brainstem and spinal cord. Powerful opioids like morphine, heroin, or fentanyl arrive with strong anchors and quickly occupy the docks, triggering effects such as pain relief, sedation, and when too many are engaged, dangerous slowing of breathing. Into this crowded harbor comes another boat, naloxone, with a sharper anchor that displaces the others and holds the spot firmly, but without triggering the same downstream signals. In this way, the harbor clears and breathing resumes. Opioid receptors are G-protein coupled receptors, most importantly the mu receptor for pain control and respiratory drive. When opioids bind, they inhibit adenylate cyclase, lower cyclic AMP, and open potassium channels while closing calcium channels. These shifts reduce neuronal excitability and neurotransmitter release. In the spinal cord, the effect is analgesia. In the brainstem, where breathing rhythm is generated, the effect is slowed respiratory drive. The same mechanism that relieves pain also threatens life when overstimulated. Naloxone is an opioid antagonist with high affinity but little intrinsic activity. By attaching to the mu receptor without activating it, naloxone prevents opioids from exerting their effects. Because it competes so effectively, even strong agonists like fentanyl are displaced. The result is rapid reversal of respiratory depression. Within minutes, a person who appeared unresponsive may open their eyes, breathe more deeply, and sometimes awaken abruptly. The speed and drama of this reversal is why naloxone is often called a rescue drug. The story, however, is not so simple. Naloxone's duration of action is shorter than many opioids. While naloxone may occupy receptors for 30 to 60 minutes, heroin or extended-release opioids can remain in circulation for hours. As naloxone clears, the opioids reoccupy their receptors and respiratory depression may recur. This explains why repeated doses or continuous observation are often necessary. The pharmacokinetics of antagonist and agonist create a race. Whichever remains longer in the body determines the lasting outcome. Consider a vignette. A young adult is found in shallow breathing with pinpoint pupils, surrounded by paraphernalia. Emergency responders administer intranasal naloxone. Within 2 minutes, the person gasps and begins breathing on their own, confusion in their eyes. Relief fills the scene, but responders know the story is not over. 30 minutes later, the same patient could drift back into respiratory depression if long-acting opioids remain. This is why transport to medical care is essential. If, in your own surroundings, someone with suspected opioid use becomes unresponsive or breathes less than 8 times per minute, professional care must be summoned immediately, regardless of temporary improvements. Naloxone also reveals another layer. Not all opioid use is recreational. Many patients take opioids legitimately for severe chronic pain or after surgery. For them, naloxone reversal may bring back pain abruptly, alongside agitation or distress. The antagonist does not discriminate between misuse and prescribed therapy. It simply displaces opioids wherever it finds them. This dual reality complicates discussions of its use but underscores its critical role in saving lives. Pharmacologically, naloxone is instructive for several reasons. First, it demonstrates receptor affinity as a determinant of effect. Whichever drug binds more tightly dominates the receptor's function. Second, it shows the difference between agonist efficacy and antagonist blockade. Naloxone has no efficacy at the receptor, but its affinity is so high that it dictates outcome. Third, it illustrates time dependence in pharmacology. Short antagonist action versus long agonist persistence can shape clinical need. On a broader level, naloxone reminds you that pharmacology is not just about desired effects, but about restoring physiology to baseline. While an agonist amplifies a function, an antagonist often rescues it by blocking overactivation. Both are tools, and the body's needs at a given moment determine which is life-saving. Your reflection here is poignant. In a single breath, you grasp how fragile the line between relief and suppression can be, and how one molecule can snatch someone back from that line. From here, curiosity extends. If receptors in the brain can be blocked to restore breathing, what about vessels that constrict and resist blood flow? How does a medicine like nitroglycerin relax their tension, and why does one small spray under the tongue ripple through the entire circulation? The story of nitroglycerin begins with a different molecular messenger, nitric oxide. When nitroglycerin enters the body, enzymes in vascular smooth muscle convert it to nitric oxide. This gas diffuses into cells and activates guanylate cyclase, increasing cyclic GMP. Elevated cyclic GMP triggers protein kinase G, which lowers intracellular calcium and dephosphorylates myosin light chains, leading smooth muscle to relax. The result is vasodilation. The effects occur in two main vascular territories. In veins, dilation increases capacity, reducing venous return to the heart. Less blood returns, so the heart fills less and works against lower preload. In coronary arteries, dilation improves blood flow around blockages, enhancing oxygen delivery to heart tissue. Both actions relieve chest pain of angina, where myocardial oxygen demand and supply fall out of balance. Administration under the tongue matters. Sublingual absorption bypasses the liver and first-pass metabolism, delivering active drug quickly to systemic circulation. Within 1 to 3 minutes, patients may feel relief. This rapid onset is crucial during acute chest pain, when time means myocardium preserved or lost. Yet nitroglycerin also carries cautions. Because it lowers systemic vascular resistance, blood pressure can fall sharply. In someone already hypotensive, this can cause dizziness, fainting, or worse. Combining nitroglycerin with drugs for erectile dysfunction, which also enhance nitric oxide pathways, can produce profound and dangerous hypotension. For this reason, clear professional guidance and protocols are essential. Imagine a scenario. A patient with known coronary disease feels heavy chest pressure while climbing stairs. They sit, place a nitroglycerin tablet beneath the tongue, and within minutes the pain eases. But if another patient with low baseline blood pressure or recent use of Sindotevil did the same, the result could be collapse. This dual potential illustrates the importance of medical context. If chest pain persists after rest or medication, or is accompanied by sweating, nausea, or radiation to the arm or jaw, urgent professional evaluation is non-negotiable. Nitroglycerin's mechanism also explains its common side effect: headache. Dilation of cerebral vessels increases intracranial blood flow, producing throbbing discomfort. This is expected, not alarming, and usually transient. Still, forewarning patients can prevent unnecessary anxiety. Your reflection here is calm. One tiny tablet holds the power to ease the crushing weight of ischemia, but its very potency means respect is required with every use. Now the thought flows naturally. If nitroglycerin widens vessels to relieve cardiac strain, what about glucose, the simplest sugar? How does placing it on the tongue restore energy to the brain? And why must caution guide its use when consciousness falters? Glucose is the body's essential fuel, especially for neurons, which depend heavily on it. When blood glucose drops too low, neurons starve of energy, leading to confusion, dizziness, and, if uncorrected, coma. Oral glucose paste, when placed in the mouth of someone awake and able to swallow, provides a rapid source of sugar. Absorbed through the gastrointestinal tract, it enters blood, raising glucose concentration and restoring cerebral metabolism. The safety condition is clear: only give oral glucose if the person is conscious and can swallow. If unconscious, giving paste risks aspiration, material entering the airway instead of the stomach. In such cases, professional medical intervention is needed urgently, with glucose administered by other routes. A vignette brings this alive. A child with diabetes appears shaky and irritable, then drowsy. A caregiver recognizes possible hypoglycemia, offers a tube of oral glucose, and the child perks up within minutes. But another patient found unconscious must not receive oral paste. Attempting it could obstruct the airway. Instead, emergency services are called, and intravenous or intramuscular routes become necessary. This simple intervention illustrates pharmacology's most direct principle. Sometimes the medicine is the nutrient itself, replacing what is missing. It also shows that even seemingly harmless agents carry rules for safe use. Your reflection rests on this. The most basic molecule, sugar, can rescue a faltering brain, yet even here, wisdom lies in knowing when and how to give it. From here, a broader curiosity emerges. You have seen drugs acting on lungs, platelets, receptors, vessels, and metabolism. But how do all these examples tie back to the central theme of pharmacology? Names, classes, actions, and contexts, so that when you learn a new medicine, you can map it with confidence across systems. You imagine a map pinned to a wall, each medicine a colored marker, each system a shaded region. When you step back, you see patterns emerge. Drugs grouped by classes, their mechanisms drawn like roads between organs. Pharmacology becomes less a scattered collection of facts and more a cartography of actions. To build this map, you start with a simple framework, the drug profile. It contains a name, a class, a mechanism of action, an indication, a contraindication, expected onset, duration, and potential side effects. Each field is a coordinate, and together they fix the drug in space so you can find it again without confusion. Take albuterol as a case. Its generic name anchors it, while its trade names vary. Its class is a beta-2 agonist, a sympathomimetic. Its mechanism is activation of receptors on bronchial smooth muscle, raising cyclic AMP, relaxing fibers, widening airways. Its indication is acute bronchospasm, as in asthma or chronic obstructive pulmonary disease. Its contraindication is uncontrolled tachycardia or certain arrhythmias, where more sympathetic drive could worsen harm. Its onset is minutes, duration a few hours. Side effects include tremor and palpitations. Each point fills the profile, and when aligned, the drug stands clearly labeled on your mental map. Now imagine aspirin. Its class is an antiplatelet, a non-steroidal anti-inflammatory drug that irreversibly inhibits cyclooxygenase in platelets. Its mechanism lowers thromboxane production, reducing aggregation. Its indication is suspected acute coronary syndrome, when a clot threatens to block coronary arteries. Its contraindication is active bleeding or severe bleeding risk. Its onset is within an hour orally, faster if chewed. Its duration spans the platelet's life. Its side effect is increased bleeding tendency, sometimes gastrointestinal discomfort. Again, the profile anchors the medicine to your map. Next, epinephrine. Its class is sympathomimetic catecholamine. Its mechanism is non-selective stimulation of alpha and beta receptors, alpha-1 constricting vessels, beta-1 accelerating heart rate, beta-2 relaxing bronchioles. Its indication is anaphylaxis, where airway compromise and hypotension threaten life. Its contraindication is relative only, as in frail patients with heart disease, but in true anaphylaxis benefit far outweighs risk. Its onset is 1 to 2 minutes intramuscular, duration 5 to 10 minutes. Side effects include palpitations, anxiety, and tremor. Its placement on the map is broad, touching multiple systems simultaneously. Then naloxone. Its class is opioid antagonist. Its mechanism is competitive binding at mu receptors, displacing agonists, restoring respiratory drive. Its indication is suspected opioid overdose with respiratory depression. Its contraindication is minimal, but caution is needed in chronic pain patients to avoid sudden distress. Its onset is 1 to 4 minutes intranasal, duration 30 to 60 minutes. Its side effects include withdrawal symptoms in opioid-dependent patients. Its marker sits in the nervous system region, yet its influence spans to breathing and consciousness. Finally, nitroglycerin. Its class is organic nitrate, a vasodilator. Its mechanism is conversion to nitric oxide, activating guanylate cyclase, raising cyclic GMP, relaxing vascular smooth muscle. Its indication is chest pain of angina or suspected ischemia. Its contraindications include hypotension and concurrent use of phosphatidyliesterase inhibitors. Its onset is 1 to 3 minutes sublingual, duration about half an hour. Its side effects include headache, flushing, and dizziness. Its place on the map is in the cardiovascular region, tied to vessels and myocardium. Profiles act like the legends on the map, clarifying each marker. When you encounter a new drug, you can slot it into the same structure: name, class, mechanism, indication, contraindication, onset, duration, side effects. This not only organizes knowledge but also shows parallels across drugs. If you learn one beta-2 agonist, you understand many others. If you grasp one antiplatelet, you see echoes in its class. Pharmacology becomes less memorization and more recognition of recurring patterns. But the map must also reflect interactions, because no drug exists alone. Consider a patient with chest pain who takes nitroglycerin. If they also take Simdatel, both act on the nitric oxide CGMP pathway, and their effects combine dangerously, dropping blood pressure too low. Or think of a patient using albuterol while also on a non-selective beta blocker. The beta blocker blocks the very receptors albuterol seeks, leaving the bronchioles tight despite inhalation. These intersections are roads that cross on your map, sometimes safely, sometimes creating collisions. Recognizing them early prevents accidents. Distribution across systems deepens the cartography. The nervous system, cardiovascular system, respiratory system, endocrine system, immune system, they overlap like neighborhoods. Epinephrine crosses between them all, its markers scattered across heart, vessels, lungs. Aspirin sits at the junction of immune and cardiovascular. Naloxone anchors in the nervous system but radiates effects to breathing. Nitroglycerin ties circulation to cardiac oxygen demand. Albuterol sits in the respiratory tract, yet tremors remind you of its influence on skeletal muscle. Each drug is never confined to one box. Its spread across the map shows both intended and side effects. To explore this more deeply, imagine tracing the path of pharmacology as a student at night. You read about receptors, their signaling cascades, their distribution in tissues. You notice that beta-1 receptors live primarily in the heart, beta-2 in the lungs, alpha-1 in vessels. You see muscarinic receptors scattered across glands, gut, and heart. Each distribution explains why selective drugs have targeted uses. A selective beta-1 blocker slows heart rate without strongly constricting airways. A selective beta-2 agonist eases breathing without overwhelming the heart. Selectivity is not absolute, but it shifts the balance of effects, making therapy more precise. Yet maps are not static. In disease, receptor density can change. Chronic heart failure upregulates some receptors, downregulates others. Chronic asthma can desensitize beta-2 receptors. Tolerance develops, altering expected curves. Your map must be flexible, updated with experience and physiology. The same drug may act differently in the same patient over time. A case illustrates this. A patient with heart failure is prescribed a beta blocker to reduce cardiac workload. Initially, fatigue worsens, because blocking sympathetic input slows the already struggling heart. But over weeks, receptor regulation changes, sensitivity improves, and the heart works more efficiently with less oxygen demand. Here the drug's true benefit emerges not at first glance, but after adaptation. Without the map of receptor regulation, such paradoxical responses confuse, but with it they make sense. Another case, a person with asthma uses albuterol daily. Over months, the relief lessens and more inhalations are needed. The map shows why. Receptors have downregulated, tolerance has emerged, responsiveness has diminished. The problem is not simply that the drug is weaker, but that the system has adapted. In such cases, reliance on professional supervision is critical, as adjustments may be needed that only careful evaluation can guide. Safety is always woven into the map. For each drug, you mark not only where it acts, but also where it must not be used. Absolute contraindications are red zones. Relative contraindications are caution stripes. For nitroglycerin, hypotension is a red zone. For aspirin, active bleeding is a red zone. For naloxone, there are few red zones, but caution stripes include chronic pain management. These visual warnings prevent missteps when fatigue, stress, or haste might otherwise lead to error. The map also teaches humility. You may think you know where each marker sits, but new information can shift boundaries. For example, aspirin long seemed a universal preventive for cardiovascular disease, yet studies revealed that in people without high risk, the bleeding outweighs the benefit. The guideline shifted and the marker moved. Pharmacology is alive, not frozen. It evolves with evidence. Now imagine stepping back from the wall. The map is large, with colors spanning every system. You see clusters, sympathomimegics grouped by receptors, antiplatelets by mechanism, nitrates by vascular target, opioids and antagonists by central nervous system action. The picture is less overwhelming than it first seemed. You no longer see hundreds of isolated facts, but families, patterns, parallels. You see that the map is navigable, that pharmacology is not a storm but a landscape. A reflection rests here. Knowledge becomes bearable when structured. What once felt like scattered pieces becomes a connected geography, and your confidence grows. Yet one more question opens. Maps show static placement, but real life is dynamic. Drugs enter, distribute, metabolize, clear, and their effects rise and fall with time. How does this temporal rhythm, onset, peak, duration, offset, shape what you observe in patients, and how can it surprise you when one drug lingers longer than another? You picture a clock face where the hands do not mark hours, but the unfolding of a medicine's effect. At 12 o'clock the dose is given. At 1 o'clock it begins to stir in the bloodstream. At 3 o'clock the effect is clear. At 6 o'clock it holds steady, and by 9 o'clock it fades. This temporal cycle, onset, peak, duration, offset, defines the lived reality of pharmacology. Every drug you study carries not only a profile of mechanism and class, but also a rhythm and time. Onset is the interval between administration and first perceptible effect. It depends on absorption, distribution, and receptor binding. An inhaled bronchodilator may act in minutes because it travels only a thin alveolar membrane to reach circulation, then directly to airway smooth muscle. A swallowed tablet may need an hour to dissolve, survive stomach acid, cross intestinal walls, and pass the liver before enough enters systemic blood. Even within one class, onset varies. Sublingual nitroglycerin eases chest pain in 2 minutes, while oral isosorbide dinitrate may take 30 minutes. The difference is not in the molecule itself, but in the path it takes. Peak effect is the moment when receptor occupancy and downstream signaling are maximized. It marks the height of the curve when relief or change is strongest. For some drugs, peak coincides with maximal plasma concentration. For others, the correlation lags. This is because drug concentration in blood does not always equal concentration at the site of action. A lipophilic sedative may linger in fat and slowly seep back, prolonging effect even as plasma levels fall. A drug that triggers long intracellular cascades may produce effects long after it has left circulation. The curve of effect is not always the curve of concentration. Duration is the span between onset and offset, the period in which benefit can be expected. It arises from clearance, tissue binding, and receptor signaling. Short-duration drugs are often chosen for emergencies: naloxone to reverse opioid overdose, adenosine to halt supraventricular tachycardia, because their quick fade limits prolonged disturbance. Long-duration drugs are chosen for chronic control: antihypertensives, anticoagulants, antidepressants, because they provide steady coverage without constant dosing. But duration also creates pitfalls. Naloxone's brief action compared to opioids means relapse into overdose is possible. Long-acting sedatives can accumulate, producing morning grogginess or confusion. Offset is the gradual or abrupt decline of effect. For competitive antagonists, offset occurs when enough drug is cleared that receptors are free again. For covalent inhibitors like aspirin on platelet Sox, offset depends not on drug clearance but on the lifespan of the platelet. This is why aspirin's antiplatelet effect lasts days, even though the drug itself is eliminated in hours. Time can be determined not only by pharmacokinetics but also by biology of the target. Consider a patient who uses albuterol for asthma. Inhaled, it acts in minutes, peaks quickly, and fades in 3 to 4 hours. Relief is fast but temporary. Contrast with salmeterol, a long-acting beta-2 agonist. It takes longer to begin, but effects last 12 hours. For quick relief, albuterol is preferred. For maintenance, salmeterol steadies control. The choice is guided not by mechanism. They both stimulate the same receptor, but by rhythm and time. Now picture nitroglycerin again. Sublingual tablets act in minutes, but relief fades within half an hour. This is enough for acute episodes, but not for prevention throughout the day. For that, patches or oral sustained release forms are used. The same molecule behaves differently in time depending on formulation. Understanding this lets you predict when relief will arrive, how long it will stay, and when risk of tolerance or accumulation emerges. Tissue reservoirs complicate the cycle. Lipophilic drugs often distribute into fat, then return slowly to blood. This explains why a single dose of diazepam may calm anxiety quickly, but sedation may linger for a day. Redistribution can also explain abrupt offsets. Intravenous anesthetics like thiopental induce unconsciousness in seconds but wear off in minutes, not because they are eliminated, but because they redistribute from brain to muscle and fat. The clock hand moves rapidly, not from clearance but from internal relocation. The elderly illustrate time's effects vividly. Reduced renal clearance slows elimination of water-soluble drugs. Reduced hepatic metabolism prolongs clearance of lipid-soluble ones. Changes in body composition increase fat stores, lengthening half-life of lipophilic agents. A drug with moderate duration in youth may linger dangerously in age. What once was an 8-hour cycle may become a 24-hour cycle. This explains why older patients often experience confusion or falls from sedatives given at standard doses. Pediatrics tells a different story. Neonates have immature metabolic enzymes and reduced kidney clearance. Their onset may be delayed, duration prolonged, offset unpredictable. As they grow, enzyme activity can exceed adult levels, shortening half-lives and demanding closer monitoring. Time itself is developmental, changing with age. Another aspect is the mismatch between subjective and objective duration. A patient may feel relief long after measurable plasma levels have declined because downstream pathways remain modulated. Conversely, they may feel recurrence of symptoms while drug is still present if tolerance has developed. The clock of perception is not always the same as the clock of chemistry. A case illustrates: a patient receives naloxone for heroin overdose. They wake, breathe, speak, and declare themselves recovered. 30 minutes later, while waiting at home, they collapse again. The clock of naloxone has run out, but heroin remains. Without understanding the rhythm, one might mistake temporary reversal for cure. This is why observation and repeated dosing under medical supervision are essential. If unresponsiveness recurs, immediate professional care is the only safeguard. Think also of anticoagulants. Warfarin does not act immediately because it reduces synthesis of clotting factors, which themselves have half-lives. The onset is delayed not by absorption but by biology. Newer anticoagulants act directly on enzymes producing effect within hours. Both reduce clotting, but their clocks differ, altering how they are started, monitored, or paused. Side effects too have rhythms. Albuterol tremor peaks shortly after inhalation and subsides as drug clears. Nitrate headaches appear within minutes of dilation, then fade as tolerance develops. Opioid-induced constipation, however, persists throughout use because receptor effects in the gut are continuous, not transient. Some adverse effects track with plasma levels, others reflect sustained system changes. This temporal awareness becomes critical in polypharmacy. A patient takes multiple drugs, each with its own clock. Some overlap in peaks, producing additive effects such as hypotension or sedation. Others offset each other, with one fading as another begins. Professional supervision charts these rhythms to avoid dangerous overlap. For you as a learner, the principle is simple. Always ask not just what a drug does, but when it does it. Reflection brings clarity. Drugs are not static tools but moving rhythms. Their clocks can run fast or slow, steady or erratic. To understand them is to read time as carefully as you read mechanism. And so the next question forms: if effects rise and fall with such rhythm, what about the unintended echoes, side effects, adverse reactions, allergies that accompany benefit? How can you distinguish them and predict their patterns across the body? You picture a stone dropped into a pond. The intended effect of a drug is like the central splash, but the ripples that radiate outward are the side effects, some gentle, some disruptive, all flowing from the same event. To understand pharmacology, you must learn to read not only the splash, but also the ripples, because they often define safety and tolerability as much as the main action does. A side effect is a secondary effect, predictable from the drug's mechanism of action, even if it is not the primary goal. For example, nitroglycerin dilates vessels to reduce chest pain, but the same dilation in the brain's vasculature produces headache. Albuterol relaxes bronchial smooth muscle, yet beta-2 receptors in skeletal muscle also respond, leading to tremor. These effects are not accidents, they are natural extensions of the drug's actions in other tissues. They are foreseeable, and by anticipating them, you can recognize them as expected rather than alarming. An adverse reaction is broader. It includes any harmful or unpleasant effect occurring at normal doses. Some are dose-dependent, such as sedation from opioids, which intensifies as receptors are more fully engaged. Others are idiosyncratic, not predicted by mechanism, such as a severe rash after exposure to an antibiotic. Still others are mediated by the immune system. A drug acting as a hapten binds to proteins and provokes antibodies, leading to allergic responses. Unlike predictable side effects, these cannot be explained purely by the main mechanism and require vigilance because they may not reveal themselves until exposure occurs. Allergic reactions deserve special care. They involve immune recognition, often mediated by IgE antibodies, mast cell activation, histamine release, and systemic consequences. Mild forms appear as rash or hives, while severe forms produce anaphylaxis, low blood pressure, airway constriction, life-threatening collapse. Distinguishing between a predictable side effect and a true allergy is vital. A patient who feels drowsy after diphenhydramine has experienced a side effect. A patient who develops hives or throat swelling has experienced an allergy. The two are not interchangeable, though in casual speech they are often conflated. The discipline of pharmacology insists on precision here, because management differs completely. Dose plays a central role in the ripple effect. Some side effects appear only when receptors outside the target tissue are engaged at higher concentrations. Beta blockers at moderate doses reduce heart rate and blood pressure, but at higher doses they may also block beta-2 receptors, worsening asthma. Calcium channel blockers relieve angina by dilating vessels, but at higher exposure they may cause ankle swelling from excessive vasodilation. These dose-related side effects are often manageable by adjusting exposure under supervision. The concept is qualitative but useful. Low concentrations may spare non-target tissues, higher concentrations engage them. Genetic variation also changes ripples. Some individuals metabolize drugs slowly, leading to accumulation and exaggerated side effects. Others metabolize quickly, requiring higher doses for effect, but risking toxicity if dosing is miscalculated. For example, codeine is a prodrug converted to morphine by CYP2D6. Ultra-rapid metabolizers may experience profound sedation and respiratory depression even at standard amounts, while poor metabolizers may feel no pain relief. In both cases, the ripples diverge dramatically because the splash enzyme activity is different at the genetic level. Interactions add further complexity. Two drugs acting on similar pathways can amplify side effects. A patient on sedatives who drinks alcohol experiences additive depression of the central nervous system. A patient on multiple antihypertensives may develop dizziness from compounded lowering of pressure. Conversely, some interactions suppress side effects. An antiemetic given with chemotherapy blunts nausea. Understanding side effects therefore means understanding not only the drug itself but also the context in which it is taken. Consider a vignette. A patient with chronic angina takes nitroglycerin and experiences throbbing headache. The symptom worries them, but a clinician explains it is a predictable effect of cerebral vasodilation, not a sign of stroke. Another patient, however, develops sudden swelling of lips and difficulty breathing after starting an ACE inhibitor. That is not a side effect, but a rare adverse reaction called angioedema, mediated by bradykinin accumulation. The first requires reassurance and adjustment. The second demands urgent intervention. If such swelling or breathing difficulty occurs after a new drug, professional evaluation must be immediate. Side effects are also time-dependent. Some occur early and fade as the body adapts. Nausea with selective serotonin reuptake inhibitors may subside after weeks as receptors adjust. Other side effects emerge only with chronic use. Long-term corticosteroids can produce osteoporosis, weight gain, or immune suppression, consequences of sustained receptor activation over months to years. Temporal awareness is crucial. The pond's ripples may spread differently depending on how long the stone remains. Some side effects, though undesirable, become useful in other contexts. Minoxidil was first developed as an antihypertensive, but its side effect of increased hair growth led to its use in treating baldness. Sindiflam was designed for angina, but its side effect of vasodilation in penile tissue made it famous for erectile dysfunction. These examples show how pharmacology's ripples can generate entirely new therapeutic uses. Side effects can thus transform from nuisances to new indications depending on context and perspective. Prediction of side effects rests on understanding receptor distribution. If a receptor is present in multiple tissues, stimulation or blockade will produce effects in all those tissues. Beta-2 receptors in lungs, vessels, and muscle explain why bronchodilation, vasodilation, and tremor cluster together. Muscarinic receptors in gut, glands, and heart explain why anticholinergic drugs dry the mouth, slow digestion, and accelerate heart rate. By mapping receptor geography, you can anticipate ripple patterns even for new drugs in development. Monitoring is the practical arm of this knowledge. Patients on drugs with known risks are observed for specific signs. Those on anticoagulants are monitored for bruising or bleeding. Those on antipsychotics are assessed for movement disorders. Those on lithium are checked for tremor, thirst, or changes in kidney function. Knowing the ripple pattern directs where to watch. This is not diagnosis but structured vigilance, observing for expected echoes of mechanism. A reflection here is soft. You realize that every action carries its shadows, and wisdom lies in expecting them rather than being surprised. Side effects are not failures of medicine, but consequences of its breadth. By naming and anticipating them, fear subsides and clarity grows. Now your question deepens. If ripples spread across tissues, what happens when two stones drop at once, when drugs interact? How do enzymes, transporters, and shared pathways turn predictable ripples into unpredictable waves? You imagine two rivers flowing into the same valley. Alone, each river follows its predictable course, nourishing fields along its banks. But when both arrive together, they merge, swell, and sometimes flood, reshaping the valley in ways neither would alone. This is the image of drug interactions. When two medicines share pathways, compete for enzymes, or influence the same physiological targets, their combined presence produces effects that may be magnified, diminished, or altered. Understanding these interactions is like predicting where the waters will meet and how high the flood may rise. Interactions can be pharmacokinetic or pharmacodynamic. Pharmacokinetic interactions change what the body does to the drug: absorption, distribution, metabolism, or excretion. Pharmacodynamic interactions change what the drug does to the body, how it binds, signals, or influences receptors and systems. Both matter, and both can shift a predictable profile into an unpredictable landscape. Absorption is the first gateway. Some drugs alter the gastrointestinal environment, affecting how others enter circulation. Antacids raise stomach pH, reducing absorption of drugs that require acidity, like certain antifungals. Calcium supplements can chelate tetracycline antibiotics, forming insoluble complexes that pass unabsorbed. The interaction occurs not at the receptor, but at the very door to the bloodstream. Timing doses separately can sometimes prevent this, but awareness is the first step. Distribution is another layer. Many drugs bind to plasma proteins such as albumin. Only unbound drug is active and able to cross membranes. When two highly protein-bound drugs are given, one can displace the other, increasing the free concentration. Warfarin, for example, is highly protein-bound. Displacement by another drug can raise free warfarin levels, intensifying anticoagulant effect and increasing bleeding risk. Here the interaction is subtle. The total amount of drug is unchanged, but its free active fraction shifts. Metabolism is perhaps the most common site of interaction. The liver's cytochrome P450 enzymes act as gates, oxidizing and preparing drugs for elimination. Inhibitors close the gate, slowing metabolism and raising drug levels. Inducers open the gate wider, accelerating metabolism and lowering drug levels. Grapefruit juice inhibits CYP3A4, increasing exposure to drugs like statins. Rifampin induces multiple P450 enzymes, reducing effectiveness of oral contraceptives. These interactions can tip therapy into toxicity or ineffectiveness. They are invisible unless anticipated, because the patient takes the same dose but experiences different exposure. Excretion, particularly renal, adds another layer. Drugs may compete for secretion into renal tubules. Probenecid, for instance, blocks tubular secretion of penicillin, prolonging its presence in blood. Altered urine pH can also shift excretion. Alkalinizing urine accelerates clearance of weak acids. Acidifying urine accelerates clearance of weak bases. These manipulations are sometimes used intentionally, but when unrecognized, they can alter drug levels unpredictably. Pharmacodynamic interactions occur when drugs act on the same system. Synergy is when combined effects exceed the sum. Alcohol and benzodiazepines both depress central nervous system activity at GABA receptors. Together, their sedation deepens to dangerous respiratory depression. Additive interaction is when effects simply sum. Two antihypertensives from different classes may lower blood pressure predictably when combined. Antagonism occurs when drugs oppose each other. A non-selective beta blocker may blunt the bronchodilatory effect of albuterol, leading to persistent wheeze despite inhalation. Interactions can be intentional, forming therapeutic strategies. In tuberculosis, multiple antibiotics are combined to prevent resistance. In HIV therapy, drugs are paired to target viral replication at different steps. In hypertension, combining agents from different classes can control blood pressure while minimizing side effects, as each targets a distinct mechanism. In these cases, synergy is harnessed, not feared, but when interactions are unplanned, risk rises. Consider a vignette. A patient with atrial fibrillation takes warfarin to reduce stroke risk. They are prescribed an antibiotic for pneumonia. Within days, bruises form easily. Gums bleed when brushing teeth. The antibiotic has inhibited warfarin metabolism, raising its level. Without adjustment, a therapeutic dose becomes dangerous. Contrast with another patient taking albuterol for asthma, while also prescribed propranolol, a non-selective beta blocker. Their wheezing worsens because propranolol blocks beta-2 receptors, opposing albuterol's effect. Both stories illustrate how predictable actions can be overturned when drugs meet. Polypharmacy intensifies the challenge. Older adults often take multiple medicines for chronic conditions: antihypertensives, antidiabetics, anticoagulants, antidepressants. Each adds markers on the map, and the lines between them grow dense. Interactions may hide until symptoms appear: dizziness from compounded blood pressure reduction, confusion from overlapping sedatives, bleeding from multiple anticoagulants. In such contexts, vigilance is essential, and professional oversight is the safeguard. Some interactions extend beyond drug pairs to food, herbs, and lifestyle. Grapefruit juice alters enzyme activity. St. John's wort induces metabolism of many drugs, lowering effectiveness of oral contraceptives or antidepressants. Alcohol interacts with countless medicines, from acetaminophen, increasing risk of liver damage, to metformin, increasing risk of lactic acidosis. Even smoking induces certain liver enzymes, changing drug clearance. The body is an open system, and all inputs can shift the pharmacological balance. Not all interactions are harmful. Sometimes one drug is designed to boost another. Ritonavir, an antiretroviral, is used at low doses to inhibit enzymes that would otherwise clear companion drugs, raising their levels and effectiveness. Levodopa for Parkinson's disease is paired with carbidopa, which prevents peripheral breakdown, ensuring more reaches the brain. These combinations exploit pharmacokinetic principles to optimize therapy. They show that knowledge of interactions is not merely defensive but can be strategic. The unpredictability of interactions often lies in individual variability. Genetic differences in enzymes mean one person may be highly sensitive to an inhibitor while another barely notices. Organ function alters outcomes. Renal impairment magnifies accumulation. Liver impairment slows metabolism. Age, nutrition, and concurrent illness all shape how interactions unfold. The rivers do not meet in the same valley for every person. The floodplain differs with terrain. Reflection here is steady. Interactions are not accidents, but consequences of shared pathways. They remind you that no drug exists in isolation. Every addition to the body enters a landscape already shaped by others, and the pattern that emerges is collective. To predict it is to think systemically, to see the whole valley rather than a single stream. And now the question shifts. If interactions show how drugs alter one another, what about the body itself adapting over time? How do tolerance, dependence, and withdrawal transform a drug's story from a short intervention to a long relationship, changing both benefit and risk with continued use? You picture a candle burning steadily in a quiet room. At first the flame is bright, filling the space with warmth and light, but as the hours pass, the wax is consumed, the flame flickers lower, and what was once strong becomes faint. In the same way, the body adapts to repeated exposure to a drug, and the effects that were once vivid gradually dim. The receptors, enzymes, and pathways that drugs engage are not passive. They adjust, recalibrate, and resist, seeking to restore equilibrium. Tolerance takes several forms. Pharmacodynamic tolerance arises when receptors downregulate or desensitize. A patient who uses albuterol daily may find that the same inhalation no longer eases breathing as effectively. Beta-2 receptors repeatedly stimulated reduce in number or responsiveness. The same drug is present, but the body's targets have shifted. Opioid tolerance follows the same principle. Mood receptors, constantly occupied, decrease in sensitivity. Over time, the same dose of morphine that once relieved pain becomes insufficient, and larger amounts are required to achieve the same effect. Pharmacokinetic tolerance involves changes in metabolism. Chronic alcohol use induces hepatic enzymes, especially CYP2E1, which accelerates clearance not only of alcohol but also of other drugs. With faster metabolism, concentrations fall more quickly, and higher or more frequent doses are required to maintain effect. Barbiturates show similar patterns, as the liver adapts to their presence by producing more enzymes. Here the tolerance arises not from receptor adaptation but from enhanced elimination. Acute tolerance can develop within hours. Nitroglycerin, when given continuously via patch, loses effectiveness within a day or two. Vascular smooth muscle adjusts, partly by depleting sulfhydryl groups needed to convert nitroglycerin into nitric oxide. To restore responsiveness, drug-free intervals are required. This phenomena illustrates that tolerance can arise quickly, not only after months of use, and that rest periods may be essential for preserving efficacy. Cross-tolerance occurs when adaptation to one drug extends to others in the same class. A patient tolerant to morphine may also show reduced response to oxycodone. A patient tolerant to alcohol may require higher doses of benzodiazepines for sedation. The shared mechanisms of action explain why adaptation to one agent alters sensitivity to its relatives. This principle complicates therapy when switching drugs, but also helps predict responses. Dependence develops when the body becomes so accustomed to the drug's presence that removal causes physiological disturbance. Physical dependence reflects adaptation at receptors, neurotransmitters, and ion channels. When opioids are withdrawn after prolonged use, neurons, no longer suppressed, fire excessively, producing agitation, sweating, and pain. When benzodiazepines are withdrawn abruptly, GABA receptors, long suppressed, rebound into excitability, producing anxiety, tremor, even seizures. Dependence is not synonymous with addiction, which involves compulsive behavior and psychological drive, but it underscores the body's reliance on the drug for balance once adaptation has occurred. Withdrawal is the visible face of dependence. Its symptoms mirror the drug's actions, but in the opposite direction. If a drug calms, its withdrawal excites. If it suppresses pain, its withdrawal produces pain. If it slows the heart, its withdrawal accelerates it. This rebound effect is the body's pendulum swinging past equilibrium after being restrained. The severity of withdrawal depends on duration of use, dose, and speed of removal. Slow tapering often allows the body to readjust receptors and signaling gradually, reducing distress. Sudden cessation shocks the system, and symptoms can be dangerous. Consider a vignette. A patient uses morphine for weeks after surgery. When stopped abruptly, they feel restless, sweaty, nauseated, and complain of muscle aches. The body, accustomed to MOOF receptor occupation, now reels from its absence. Another patient uses nitroglycerin patches around the clock. After days, the angina returns despite patches because tolerance has developed. A physician instructs to remove the patch at night, allowing receptors to reset. In both cases, adaptation is at the core, the body adjusting either by reducing responsiveness during use or by reacting violently after withdrawal. Tolerance and dependence are not always negative. In some cases, they represent protective adaptation. Caffeine increases alertness by blocking adenosine receptors. With chronic use, receptors upregulate. lessening caffeine's effect but also dampening withdrawal fatigue. The body, by adapting, avoids extremes. Yet in therapeutic contexts, such adaptation complicates dosing and long-term management. Professional oversight becomes essential, as increasing doses can raise risk of toxicity while failing to restore benefit fully. Psychological dependence adds another dimension. Beyond physical adaptation, drugs can create strong emotional or cognitive associations. A patient may crave the relief or euphoria seeking the drug even in absence of pain or medical need. This craving is tied to reward pathways, especially dopamine in the mesolimbic system. Unlike physical dependence, which manifests as bodily symptoms, psychological dependence drives behavior. Both can coexist, reinforcing one another and deepening the challenge of discontinuation. Long-term adaptations may persist even after drug removal. Some changes in receptor density or intracellular signaling can take weeks to normalize. This is why antidepressants or antipsychotics, when discontinued, may lead to rebound symptoms if not tapered carefully. The nervous system, accustomed to altered serotonin or dopamine signaling, must gradually restore its own balance. Abrupt change overwhelms the adaptive processes, and symptoms emerge. Tolerance is sometimes misinterpreted by patients. A person may believe a medicine has stopped working when in fact the body has recalibrated. Without understanding adaptation, they may increase their own doses unsafely. Education helps frame tolerance not as failure but as biology. If chest pain recurs despite nitroglycerin or pain persists despite opioids, the answer is not simply more of the same but a reassessment of the strategy. This is why professional guidance is vital to differentiate between progression of disease and adaptation to therapy. The concept of dependence also raises ethical and social considerations. A patient using opioids for chronic cancer pain may develop physical dependence, but this is not addiction. Their use is therapeutic, guided, and necessary. Stigma arises when dependence is conflated with misuse. Distinguishing these terms with precision prevents misunderstanding and ensures compassionate care. Reflection here is contemplative. The body is not a passive stage but an active participant. It learns, adapts, and resists. Drugs are not one-time visitors but partners in dialogue, and the body reshapes itself in response. Sometimes this partnership is harmonious, sometimes turbulent, but always dynamic. And now your thought advances further. If tolerance and dependence show long-term adaptation, what about the very beginnings when a drug first enters the body? How does absorption, distribution, metabolism, and elimination shape the curve of exposure? And how do these processes differ among drugs, routes, and individuals? You imagine a traveler setting out on a long journey across a vast landscape. At first, they must find a way past the gates of the city. This is absorption, the process of entering the body's circulation. Then they travel along roads, some narrow and some wide, distributing themselves to different destinations. This is distribution. At last they arrive at checkpoints where their tickets are altered or stamped for exit. This is metabolism. Finally, they reach the border where they are escorted out of the territory. This is elimination. Pharmacokinetics is the study of this journey, the body's handling of a drug from entrance to departure. Absorption begins at the site of administration. For oral drugs, the digestive tract is the gate. The drug must dissolve, cross membranes of the intestine, and enter blood vessels that lead first to the liver. Factors like solubility, stomach acidity, and the presence of food alter this passage. Lipophilic molecules cross membranes more easily than hydrophilic ones, but hydrophilic molecules may use transporters. Some drugs degrade in stomach acid, so they are given as enteric-coated tablets or as prodrugs that survive until activation in the intestine. Absorption can be slowed by delayed gastric emptying, as occurs with certain illnesses, or accelerated when the stomach is empty. Not all routes require digestion. Intravenous administration bypasses absorption completely, delivering the drug directly to circulation. Intramuscular or subcutaneous injections deposit drugs into tissues, where they diffuse gradually into blood, rate influenced by blood flow to the site. Inhaled drugs diffuse rapidly across the thin alveolar membrane, providing near instantaneous absorption. Sublingual and buccal routes bypass the liver's first-pass metabolism, sending drugs directly to systemic circulation. Each route is like a different gate for the traveler. some crowded with guards, some open and direct. Once in circulation, distribution determines where the drug travels. Plasma proteins act like carriages. Drugs that bind strongly to albumin are carried in bound form, unable to cross membranes until released. Tissue perfusion matters. Organs with high blood flow, liver, kidneys, brain, receive drug rapidly, while fat and bone receive it slowly. Lipophilic drugs accumulate in fat stores, forming reservoirs that release the drug slowly over time, extending duration. Hydrophilic drugs remain largely in plasma and interstitial fluid. The blood-brain barrier, with tight endothelial junctions, restricts many drugs from entering the central nervous system unless they are lipophilic or transported actively. This explains why some drugs act on the brain while others, despite being in blood, do not. Metabolism alters the traveler's ticket. The liver is the main checkpoint, with enzymes in hepatocytes converting drugs into more water-soluble forms for elimination. Phase 1 reactions include oxidation, reduction, and hydrolysis, often mediated by cytochrome P450 enzymes. These reactions may inactivate drugs, activate prodrugs, or form active metabolites. Phase 2 reactions add groups like glucuronide or sulfate, further increasing solubility. Together, these processes prepare drugs for renal or biliary excretion. Metabolism is highly variable. Some individuals inherit fast or slow enzyme activity. A slow metabolizer may accumulate toxic levels at standard doses, while a fast metabolizer may clear the drug so quickly that it never reaches therapeutic effect. Enzyme induction by chronic drug use or diet accelerates clearance, while inhibition by other drugs or food slows clearance. Grapefruit juice inhibiting CYP3A4 exemplifies how even a fruit can reshape pharmacokinetics. Elimination is the final step. The traveler leaving the body. The kidneys filter plasma, secrete drugs into urine, or reabsorb them depending on solubility and pH. Hydrophilic metabolites are excreted readily, while lipophilic drugs may be reabsorbed unless metabolized. Urine pH can tilt this balance. Acidic urine enhances excretion of basic drugs. Alkaline urine enhances excretion of acidic ones. Biliary excretion returns drugs to the intestine, where some may be reabsorbed in enterohepatic circulation, prolonging presence in the body. Lungs eliminate volatile anesthetics and alcohol, while sweat and saliva provide minor routes. Half-life quantifies the rhythm of elimination, the time required for plasma concentration to fall by half. A drug with a short half-life requires frequent dosing to maintain levels, while a long half-life allows once-daily administration. Steady state is reached when drug input equals output, usually after 4 to 5 half-lives of consistent dosing. This balance explains why chronic medications take days to reach full effect, and why stopping them takes days to fully clear. Consider a vignette. A patient begins warfarin, an oral anticoagulant. They take a pill, but clotting does not change immediately. The drug is absorbed and distributed quickly, but its effect depends on metabolism of clotting factors, which takes days. Another patient receives intravenous morphine for pain. Relief is rapid, as absorption is bypassed, distribution quick, and effect immediate. Yet elimination means the relief fades in hours, requiring repeated dosing. A third patient uses a nitroglycerin patch. Drug is absorbed through skin slowly, distributed steadily, metabolized by the liver, and eliminated by kidneys. The effect is prolonged, but tolerance develops if patches are not cycled. Individual differences alter these stories. An older adult with reduced kidney function accumulates drugs cleared renally, risking toxicity even at standard doses. A newborn with immature liver enzymes metabolizes poorly, prolonging half-life. A genetic variant in CYP2C19 changes how proton pump inhibitors are metabolized, altering acid suppression. Disease states also matter. Heart failure reduces perfusion, slowing distribution. Cirrhosis impairs metabolism. Dehydration reduces renal clearance. Pharmacokinetics is thus personal, not universal. The concept of volume of distribution helps quantify how widely a drug spreads. A drug confined to plasma has a small volume, while one that penetrates tissues deeply has a large volume. This influences loading doses. Large volumes require larger initial amounts to fill reservoirs before plasma levels rise. Digoxin, with a high volume of distribution in muscle, requires careful loading to achieve therapeutic effect. Aminoglycosides, confined largely to extracellular fluid, distribute less widely but require monitoring because accumulation in kidneys and ears can be toxic. Bioavailability measures how much of the administered dose actually reaches systemic circulation. Intravenous routes provide 100%, but oral routes may be reduced by incomplete absorption or first-pass metabolism. Some drugs, like propranolol, have low oral bioavailability, requiring higher doses orally than intravenously. Prodrugs exploit this concept. Enalapril is inactive until metabolized in the liver to enalapril at its active form. Here metabolism is not just clearance but activation. Reflection here deepens. You see that every drug's effect is not only what it does but how it travels. Absorption, distribution, metabolism, and elimination are not abstract categories but living stages of a journey. To follow the traveler across this map is to understand why two patients may experience the same drug so differently, why timing matters, and why monitoring is essential. And now your curiosity rises again. If pharmacokinetics describes the body's handling of the drug, what about pharmacodynamics, the drug's handling of the body? How do receptors, second messengers, and system responses translate molecules into sensations, relief, or risk? You imagine a lock set into a door, waiting for the right key. The key is a drug molecule, the lock is a receptor, and the door leads to changes within the cell. When the key fits, the door opens, and a cascade of events follows. Engines shift, enzymes activate, signals propagate. This is pharmacodynamics, the study of how drugs exert their effects on the body, how chemical structures translate into physiological responses. If pharmacokinetics is the story of the traveler moving through the land, pharmacodynamics is the story of the traveler's interactions with the inhabitants. Receptors are the main actors. They are proteins designed to sense signals, whether hormones, neurotransmitters, or drugs. When a drug binds, it may act as an agonist, activating the receptor to mimic natural signals. Morphine is an agonist at mu and opioid receptors, producing analgesia by mimicking endorphins. Albuterol is an agonist at beta-2 adrenergic receptors, mimicking adrenaline's effect to relax airway muscles. Other drugs act as antagonists, fitting into the lock but not turning it, blocking the door from opening. Naloxone is an antagonist at mu receptors, preventing opioids from acting. Beta blockers are antagonists at beta-1 receptors, slowing heart rate and reducing workload. Partial agonists both open and block, producing less effect than a full agonist but preventing others from binding. Buprenorphine is one such drug, providing limited opioid effect while blocking stronger opioids from taking hold. Receptor families are diverse. Ligand-gated ion channels open directly when a ligand binds, allowing ions to flow instantly, as seen with nicotinic acetylcholine receptors at the neuromuscular junction. G-protein-coupled receptors, like adrenergic and muscarinic receptors, trigger intracellular signaling cascades, amplifying the message. Enzyme-linked receptors, such as insulin receptors, activate intracellular enzymes that regulate growth and metabolism. Nuclear receptors, like those for steroid hormones, act slowly, entering the nucleus to alter gene transcription. Each receptor type defines the tempo and scale of response, from milliseconds at ion channels to hours at nuclear receptors. Dose-response relationships describe how effect changes with concentration. At low doses, little effect is seen. As dose increases, more receptors are occupied, and effect rises until a plateau is reached. The concentration that produces 50% of maximum effect is called the EC50, a measure of potency. A more potent drug requires less to achieve the same effect, but potency does not equal strength. It simply reflects how tightly the drug binds and activates. Efficacy, the maximum effect achievable, is distinct. Morphine and codeine differ in potency, but morphine has higher efficacy, capable of greater analgesia. Naloxone has no efficacy. It binds tightly but produces no activation. Spare receptors explain why sometimes full effect is achieved without full occupancy. In certain systems, such as cardiac muscle, only a fraction of receptors need be activated for maximal response. This provides a buffer, ensuring sensitivity. It also means that antagonists can blunt effect without blocking every receptor, as some remain unoccupied but insufficient to produce full action. Affinity measures how tightly a drug binds. Efficacy measures what it does once bound. A drug may have high affinity but low efficacy, clinging firmly yet producing little activation, as with partial agonists. Another may have moderate affinity but high efficacy, needing higher concentration to bind but producing strong effect once engaged. This distinction shapes clinical use. A partial agonist with high affinity can outcompete a full agonist, reducing overall effect, useful in treating dependence, as with buprenorphine limiting opioid euphoria. Selectivity describes preference for one receptor subtype over others. Albuterol favors beta-2 receptors, relaxing airways more than stimulating the heart. Yet selectivity is relative, not absolute. At higher concentrations, beta-1 receptors in the heart may also be engaged, producing tachycardia. No drug is perfectly selective, and side effects often arise from spillover onto other receptors. The therapeutic index reflects the balance between desired and undesired effects, the ratio between the dose that produces benefit and the dose that causes harm. A wide index, as with penicillin, offers safety. A narrow index, as with digoxin or lithium, demands careful monitoring. Signal transduction amplifies receptor binding into cellular responses. One ligand binding may activate a G protein, which stimulates adenylate cyclase, raising cyclic AMP, activating protein kinase A, phosphorylating multiple targets. One binding event multiplies into thousands of intracellular changes. This amplification explains why low concentrations can produce profound effects and why subtle disruptions can cascade into large outcomes. Feedback systems modulate this. Desensitization dampens signaling with prolonged stimulation, while upregulation increases sensitivity after chronic blockade. These adjustments mirror the tolerance and dependence seen clinically. Systems-level dynamics add another layer. Drugs rarely act on one receptor in one tissue only. They influence networks. Epinephrine acts on alpha receptors in vessels, beta-1 receptors in heart, beta-2 receptors in lungs. The integrated outcome is increased blood pressure, increased heart rate, and bronchodilation. A coordinated sympathetic surge, blocking one receptor type shifts the balance. A selective beta-1 blocker slows the heart but leaves bronchioles open. A non-selective blocker slows the heart and may constrict airways. Systemic pharmacodynamics is the interplay of multiple receptors across multiple organs. Consider a vignette. A patient takes propranolol, a non-selective beta blocker for hypertension. Their blood pressure improves, but when they develop asthma, inhaled albuterol fails to relieve wheezing. The propranolol blocks beta-2 receptors, antagonizing the bronchodilator. Here pharmacodynamics explains the paradox. One drug's receptor blockade cancels another's receptor stimulation. Another patient takes aspirin for chest pain. It irreversibly inhibits platelet CO-COX, preventing thromboxane formation, reducing clot growth. The patient later notices bruising more easily. This is not separate from its main action, but the same mechanism expressed in skin vessels instead of coronary arteries. Allosteric modulation introduces another dimension. Some drugs do not bind to the active site, but to another site, altering receptor shape. Benzodiazepines bind allosterically to GABA-A receptors, increasing the effect of GABA without directly activating the receptor. This produces anxiolysis and sedation, but only in the presence of GABA. Such modulation allows fine-tuning, amplifying natural signals rather than overriding them. Negative allosteric modulators, conversely, reduce receptor responsiveness. These subtleties broaden pharmacodynamic control. Receptor polymorphisms add variability. Genetic differences alter receptor structure, changing affinity or efficacy of drugs. A patient may require higher doses of beta blockers because their receptors bind less tightly. Another may experience exaggerated response to opioids due to receptor variants. Personalized pharmacodynamics emerges here, where genetics guides therapy. This is the horizon of precision medicine, matching drug choice not only to disease but to the individual's receptor landscape. Time also shapes pharmacodynamics. Acute effects may differ from chronic. Beta agonists cause bronchodilation immediately, but with chronic use, receptor desensitization blunts effect. Antidepressants increase serotonin quickly, but mood improvement emerges only after weeks as downstream gene expression and neuroplastic changes develop. The immediate receptor action is only the first step. the clinical outcome may lag, shaped by longer-term adaptations. Reflection here is steady. You see that pharmacodynamics is the language by which molecules converse with cells. Some speak loudly as agonists, some quietly as partial agonists, some block entirely as antagonists. Each word spoken echoes through pathways, amplified, balanced, and integrated into the body's symphony. And now curiosity stirs again. If pharmacokinetics and pharmacodynamics describe how drugs move and act, how do clinicians decide which drug at what dose and for which patient? What principles guide safe and effective choice amid so many variables? You imagine standing at a crossroads with many paths stretching into the distance, each path representing a potential drug, each signpost marked with promises and warnings. To choose wisely, you need more than a map of pharmacokinetics and pharmacodynamics. You need principles that balance benefit and risk, science and circumstance, patient and disease. Drug selection is not random, it is guided by a structured logic, where each decision rests on pillars of safety, efficacy, suitability, and evidence. The first principle is indication. A drug must be chosen for a reason grounded in physiology and supported by data. If a patient presents with chest pain due to ischemia, nitroglycerin is indicated because it dilates vessels and reduces cardiac workload. If a patient suffers from acute bronchospasm, albuterol is indicated because it relaxes airway smooth muscle. Indication defines the why of therapy, the match between a drug's action and a patient's need. Without a valid indication, a drug is at best useless and at worst harmful. The second principle is contraindication. Here you weigh conditions where giving the drug could cause more harm than benefit. Aspirin is contraindicated in active bleeding. Nitroglycerin is contraindicated in severe hypotension or recent use of phosphodiesterase inhibitors. Beta blockers are contraindicated in acute asthma. Contraindications are like warning signs blocking certain roads. Some are absolute, never proceed under any circumstance, while others are relative, where risk may be outweighed by greater danger if untreated. Recognizing these boundaries prevents predictable harm. The third principle is efficacy. Among possible options, you ask which drug is most effective for the condition. Efficacy is not only about clinical trials but also about context. Albuterol is highly effective for acute asthma but not for chronic prevention. Inhaled corticosteroids excel at long-term control. Naloxone is highly effective for reversing opioid overdose but has no role in treating anxiety. Matching efficacy to context ensures the chosen drug can actually achieve the intended outcome. The fourth principle is safety. Even if a drug works, its potential harms must be balanced against benefit. This balance is captured in the therapeutic index, the ratio between toxic dose and effective dose. Drugs like penicillin have wide safety margins, allowing flexibility. Drugs like digoxin or lithium have narrow margins, demanding precise monitoring. Safety also includes side effects, interactions, and the patient's comorbidities. A safe choice in one patient may be unsafe in another. The fifth principle is patient suitability. Here you consider individual factors: age, weight, organ function, genetics, pregnancy status, and adherence potential. An elderly patient with kidney impairment may not tolerate aminoglycosides. A child may require weight-based dosing to avoid toxicity. A pregnant patient must avoid drugs that cross the placenta and harm the fetus. Suitability also includes practical issues. Can the patient afford the drug, access it easily, and adhere to its regimen? Even the most effective therapy fails if it cannot be taken consistently. Evidence-based medicine is the framework that integrates all these principles. Clinical trials, guidelines, and meta-analyses provide the foundation, but they are not rigid dictates. They are informed pathways which must be interpreted in light of individual variation. Evidence is population level, practice is personal. The art of selection lies in applying general knowledge to specific people without losing either rigor or compassion. Polypharmacy complicates decision-making. A patient may already take several medications, and adding one more risks interactions. Each new addition must be justified not only by its own indication, but by its compatibility with the existing regimen. If two drugs overlap in mechanism, such as dual anticoagulants, bleeding risk rises. If they oppose one another, like beta blockers and beta agonists, effectiveness falters. Rational prescribing means pruning unnecessary drugs as much as adding needed ones. Monitoring transforms selection into a dynamic process. Choosing a drug is not the end, but the beginning. You must track effectiveness, side effects, and adherence. Adjustments may be needed as the patient's condition evolves, as organs change with age, or as tolerance develops. Drug selection is therefore iterative, revisited with each new development, never static. Consider a vignette. A patient presents with crushing chest pain. Indication suggests nitroglycerin, aspirin, and perhaps morphine for relief. Safety considerations prompt a blood pressure check before nitroglycerin and a bleeding history before aspirin. Suitability ensures the patient can chew aspirin for faster absorption. Evidence-based guidelines confirm this approach as standard for suspected myocardial infarction. Yet the same scenario in a patient with severe hypotension would alter the choice: no nitroglycerin, perhaps oxygen instead. The principles flex with context, but their structure remains. Another case, a patient with new asthma symptoms. Albuterol provides quick relief, but guidelines suggest adding inhaled corticosteroids for long-term control if symptoms persist. Here, efficacy directs albuterol for acute episodes and steroids for prevention. Safety prompts review of side effects like tremor or oral candidiasis. Suitability ensures the patient can use an inhaler correctly. Evidence ties choices to reduced hospitalizations and improved quality of life. Without these layered considerations, prescribing would be blind. Drug selection also involves ethical dimensions. Cost matters. A highly effective drug may be inaccessible to some patients, forcing alternatives. Equity matters, ensuring therapies are chosen without bias or neglect. Autonomy matters, patients should understand risks and benefits to make informed choices. Shared decision-making transforms prescribing from dictation into partnership. Precision medicine represents the horizon of drug selection. As genetic testing becomes more accessible, choices can be guided by individual enzyme activity, receptor variants, or disease subtypes. A patient with HER2-positive breast cancer benefits from targeted monoclonal antibodies, while another without that receptor does not. A patient with slow CYP2D6 metabolism avoids codeine, while another with ultra-rapid metabolism avoids overdose risk. This tailoring elevates selection from population averages to individual optimization. Reflection here is balanced. Drug selection is both science and art. The science provides frameworks, indication, contraindication, efficacy, safety, suitability, evidence. The art applies them to real lives where no patient is average and every choice has ripples. And now you look ahead. If selection defines what to give, how is it actually given? How do routes of administration shape onset, intensity, and safety, and why do some drugs succeed only when delivered in very specific ways? You imagine a set of doors leading into a great hall. Each door opens to the same room, yet the path taken determines how quickly you arrive, how much you can carry, and what obstacles you face along the way. These doors are the routes of drug administration, the gateways by which molecules enter the body to reach their sites of action. The same substance may act differently depending on whether it is swallowed, injected, inhaled, absorbed under the tongue, or placed on the skin. To understand pharmacology fully, you must walk through each of these doors and trace the consequences. The oral route is the most familiar. Swallowing a pill or liquid sends the drug through the gastrointestinal tract, where it dissolves, crosses intestinal membranes, and enters the portal circulation. The liver is the first major checkpoint, metabolizing some fraction of the drug before it reaches systemic blood. This is the first pass effect, and it explains why some drugs require higher oral doses compared to intravenous routes, and why some, like nitroglycerin, are ineffective if swallowed but potent if placed sublingually. Oral administration is convenient and non-invasive, but absorption is slow and variable, influenced by food, gut motility, and pH. It is suited for chronic conditions where rapid onset is not critical, but not for emergencies. The intravenous route bypasses absorption entirely, delivering drug directly into systemic circulation. Onset is immediate, bioavailability complete, and dosing precise. It is the route of choice for emergencies: naloxone in opioid overdose, epinephrine in cardiac arrest, morphine for severe pain. Yet it requires trained personnel, sterile technique, and carries risks of infection, infiltration, and rapid toxicity if miscalculated. Intravenous administration is like walking straight through the main gate into the hall, fast but demanding precision. Intramuscular injections deposit drug into muscle tissue, where it diffuses into capillaries. Onset is slower than intravenous, but faster than oral. Absorption depends on blood flow. Well-perfused muscles absorb quickly, while poor circulation slows uptake. Epinephrine and anaphylaxis is often delivered intramuscularly because it provides rapid systemic effect without requiring intravenous access. Depot formulations exploit this route, releasing drugs slowly over weeks, as with certain antipsychotics or hormonal therapies. The muscle acts as a reservoir, offering both rapid uptake and long-term storage depending on formulation. Subcutaneous injections place drug into fat beneath the skin. Absorption is slower, influenced by blood flow and formulation. Insulin is commonly delivered this way, allowing gradual entry into circulation. Subcutaneous injections are less painful than intramuscular but limited in volume. They illustrate how tissue properties shape pharmacokinetics. Fat absorbs slowly, muscle faster, vein instantly. Each layer of the body offers a different tempo. Inhalation offers one of the fastest non-intravenous routes. Drugs delivered as aerosols or gases cross the thin alveolar membrane into pulmonary circulation, reaching the heart and brain within minutes. Albuterol inhalers provide rapid bronchodilation. Volatile anesthetics induce unconsciousness quickly. Inhalation delivers high local concentrations to the lungs while minimizing systemic exposure, useful for respiratory diseases. Yet technique matters. Incorrect inhaler use reduces efficacy. The lung, with its vast surface area and rich blood supply, is a powerful portal. The sublingual and buccal routes place drugs under the tongue or against the cheek, where they dissolve and diffuse directly into venous blood. This bypasses first-pass metabolism and offers rapid onset. Nitroglycerin under the tongue relieves angina in minutes, a feat impossible if swallowed. Buccal tablets of certain hormones or analgesics exploit this mucosal route for steady absorption. The mouth's thin vascular membranes provide a shortcut into systemic circulation, ideal for drugs destroyed by stomach acid or liver metabolism. The rectal route, though less common, can be valuable when oral administration is not possible, such as in vomiting or unconsciousness. Drugs delivered rectally may partially bypass the liver, depending on depth of placement. Absorption is erratic but useful in pediatrics or palliative care. Suppositories for seizures, nausea, or pain provide alternatives when other routes are impractical. Though less predictable, this doorway has its role. The transdermal route uses skin as a slow but steady gateway. Patches containing drug release it gradually into systemic circulation, avoiding peaks and troughs. Nicotine patches assist with smoking cessation. Fentanyl patches provide chronic pain relief. Nitroglycerin patches prevent angina. The skin's barrier requires drugs to be lipophilic and potent in small doses. Transdermal delivery is convenient and improves adherence, but it is unsuitable for drugs requiring rapid onset. It is like a narrow side door, opening slowly but reliably. Other specialized routes extend the list. Intrathecal administration delivers drug directly into cerebrospinal fluid, bypassing the blood-brain barrier, as with certain chemotherapies or analgesics. Intraosseous access provides rapid entry into circulation via bone marrow, useful in emergencies when veins are inaccessible. Topical application targets local effects on skin or eyes, minimizing systemic exposure. Each route has unique advantages, limitations, and contexts. Consider a vignette. A patient with severe chest pain places a nitroglycerin tablet under the tongue and feels relief within minutes. Another patient swallows the same drug and feels no effect, as first-pass metabolism destroys it. A child with an asthma attack inhales albuterol, bronchioles relax rapidly. A diabetic adult injects insulin subcutaneously, glucose control improves steadily. An unconscious overdose patient receives naloxone intravenously, awakening within seconds. Each outcome reflects not only the drug's mechanism, but the chosen route, the doorway that determines speed, intensity, and success. The route also shapes safety. Intravenous administration delivers all at once. If too much is given, toxicity occurs instantly. Oral routes buffer toxicity, as absorption takes time and the liver metabolizes some portion. Transdermal routes can lead to accumulation if patches are layered inadvertently. Inhalation requires correct technique. Poor coordination wastes the dose. Route is not a neutral detail, but a determinant of risk. Patient factors guide route choice. Children may resist injections, favoring oral or inhaled forms. Elderly patients with difficulty swallowing may require liquid or transdermal forms. Patients with vomiting cannot take oral medications. Emergencies demand routes with rapid onset, intravenous, intramuscular, inhaled, while chronic conditions favor routes with convenience and adherence. Matching route to patient ensures both efficacy and practicality. Formulation technology continues to expand options. Nanoparticles, liposomes, and implantable devices deliver drugs more precisely, targeting tissues while sparing others. Oral drugs are engineered to resist stomach acid, release slowly, or release only in the intestine. Transdermal systems are refined for better penetration. Inhalers are designed for precise particle size to reach small airways. Routes evolve with innovation, broadening what is possible. Reflection here is precise. You realize that a drug's effect is inseparable from the path it takes. The same molecule swallowed, injected, or inhaled may tell entirely different stories. Routes are not mere technicalities, they are integral to pharmacology's language. And now curiosity deepens again. If routes determine how drugs enter, what about the obstacles they face once inside? How does the body protect itself from foreign substances, and how do barriers like the blood-brain barrier, liver enzymes, and renal filters both defend and complicate therapy? You imagine a quiet pharmacy at night, shelves lined with vials and ampules that look inert until you remember that every container holds a living chemistry, molecules that breathe with light, heat, water, and oxygen. Handling and stability are the silent half of pharmacology. You can choose the right drug at the right moment by the right route, yet still change its nature if you store it poorly, mix it unwisely, shake it too hard, or expose it to the wrong light. You learn to see each bottle not as a static thing, but as a small ecosystem with rules. Stability begins with the triad of environment, temperature, light, and moisture. Temperature guides reaction speed. Warmer conditions accelerate hydrolysis and oxidation. Colder conditions slow them until cold itself becomes a hazard by precipitating solutes or denaturing proteins. Light, especially high-energy blue and ultraviolet, can cleave bonds or generate reactive species that march through solutions like sparks along dry grass. Moisture, even as ambient humidity, feeds hydrolysis in powders and destabilizes tablets not protected by proper coatings. The amber glass vial and foil blister are not decorations, they are shields against photons and water vapor, chosen to keep chemistry asleep until needed. Degradation pathways are few in name, but many in consequence. Hydrolysis breaks susceptible bonds when water insinuates itself. Esters and lactams are classic targets, slowly opening into less active or toxic fragments. Oxidation steals electrons, often initiated by dissolved oxygen, trace metals, or light. You see it when clear solutions amber over time, or when a faint sharp odor creeps into a preparation. Isomerization flips a molecule's handedness, turning an active orientation into a weak one, a subtle shift visible only to receptors that suddenly seem deaf. Photolysis cuts apart chromophoric bonds under light exposure. Nitroprusside and amphotericin formulations illustrate how photons can be catalysts in disguise. Polymerization, less common, can cross-link reactive intermediates, thickening a solution into a gel that no longer flows or functions. Each pathway writes a different signature: color change, precipitation, gas formation, altered pH, loss of potency signals that a stable drug has drifted. Packaging and closures are chosen to interrupt these pathways. Amber glass filters light. Low extractable plastics reduce leached plasticizers that seed reactions. Silicone-coated stoppers minimize absorption and shear during piercing. Oxygen-impermeable layers slow oxidation. Desiccant canisters and caps scavenge moisture for hygroscopic tablets. Blister packs isolate each dose from air until the moment of use. Even the headspace gas matters. Nitrogen or argon displaces oxygen above delicate solutions, tempering oxidative currents before they start. What looks like excess air in an ampule may be deliberate. composition chosen to protect rather than to fill. Some molecules refuse to sit quietly next to plastics. Adsorption is the silent thief. Nitroglycerin clings to polyvinyl chloride tubing, insulin binds to infusion set surfaces, and certain monoclonal antibodies adhere to plastic interfaces when concentration is low or flow is sluggish. The result is underdelivery at the bedside, despite perfect calculation on paper. Material choice changes the equation. Glass syringes, non-PVC tubing, and surface-treated sets reduce losses by minimizing attractive interactions. Flow rate and priming techniques matter too. Filling the line with drug solution before starting a slow infusion can saturate binding sites and prevent ongoing loss. Proteins and peptides carry their own fragility. They are folded sculptures whose function depends on shape held by hydrogen bonds, salt bridges, and hydrophobic cores. Heat can unravel them. Cold can form ice crystals that shear interfaces, and vigorous shaking can whip air into the solution, creating foam that stretches molecules at the gas-liquid boundary until they fragment or aggregate. You handle such preparations gently, slow inversion instead of shaking, vented needles to avoid pressure jets, avoidance of unnecessary transfers. Visual inspection is crucial. Fine opalescence may be normal for some biologics, but visible particles or gels suggest aggregation that can trigger immune reactions rather than therapeutic ones. When a label reads "do not shake," it is not etiquette but engineering. Reconstitution is a moment of creation. A vial of powder sleeps stable for months because water, the universal reactant, is absent. When you add diluent, the clock starts. Solvent choice, volume, and order of mixing affect pH and ionic strength, which in turn set the rate of hydrolysis and the solubility of excipients. Too rapid a stream can carve channels in the powder cake, leaving clumps that dissolve slowly or not at all. Too vigorous agitation can force protein denaturation. Gentle swirling, sufficient time to clarify, and adherence to the recommended diluent protect the intended microenvironment. Beyond use times begin here. Unlike manufacture expiration, which covers sealed stability, these shorter windows reflect the reality of opened vials where microbes, oxygen, and moisture have access. Compatibility is the quiet negotiation between molecules sharing a line, a bag, or a syringe. Some combinations look fine until ions meet and form insoluble salts. Calcium and phosphate can precipitate as microscopic crystals that grow, then lodge where they should not. Others precipitate when pH drifts outside a narrow range. Weak bases fall out in alkaline solutions, weak acids in acidic ones. The Y site where two infusions join is a chemistry set in miniature, with contact time measured in seconds, often enough for a haze to appear if the pairing is poor. Visual clarity is not a guarantee, but cloudiness is a warning. Any sign of turbidity, color change, or gas release signals a mixture that no longer matches the labeled drug. When the stakes are high, separation in time or line preserves both therapies and the patient's safety. Cold chains translate chemistry into logistics. Some vaccines and biologics require a narrow temperature band from factory to administration. A freeze episode can rupture emulsions or crystallize components, and overheating can denature proteins irreversibly. Temperature indicators on cartons are not bureaucracy, they are records of molecular history. A vial that traveled warm for a day may look identical to a perfect one, yet its antigen may be silent. You imagine molecules as delicate instruments. They need tuning and careful transport to play their intended note. The calendar on the label speaks two languages: expiration and beyond use. Expiration is the manufacturer's promise of quality and potency in unopened containers stored as directed, often supported by long-term stability studies. Beyond use is the practitioner's promise after opening or reconstitution, reflecting microbial risk and accelerated chemistry once protective barriers fall. A sterile, preservative-free vial open to the air becomes a different object, with a short horizon that protects patients from inadvertent contamination and from degradation products that rise quickly. Respecting these times is another form of dosing. You dose not only the patient with drug, but the drug with time. Visual inspection is your stethoscope for solutions. You hold a syringe to light and look for fibers, crystals, or haze. You tilt a bag against a dark background to catch opalescence. You note any color shift from clear to straw, straw to brown. You listen too for a soft hiss from a vial that should be quiet, a sign of unexpected gas production. You feel for resistance when pushing medication through a filter that suddenly clogs, perhaps precipitate forming unseen. These senses applied calmly intercept errors before they enter a vein. When inspection raises concern, the safest act is to discard and prepare anew. Waste is regrettable, harm is not reversible. Handling extends beyond chemistry to human factors. Look-alike and sound-alike names sit on adjacent shelves. Similar labels and fonts blur under dim light. A tall man lettering convention or separate bin may prevent a vial of epinephrine intended for intramuscular use from being confused with a different concentration intended for intravenous routes. Barcodes, double checks, and standardized trays are not signs of mistrust but of respect for the brain's limits under pressure. Stability is also cognitive. A stable system makes the right action easier and the wrong action harder. Some drugs warn you with scent and feel. Alcohol-based preparations evaporate cool against the skin. An isopropyl odor should never emanate from a syringe intended for injection. Certain oxidized solutions release a vinegar-like tang. Some deteriorated anesthetics smell sweetly off. While you would never rely solely on smell, your awareness can trigger a second look. Touch, too, tells of temperature excursions. A refrigerated biologic that arrives warm merits quarantine and inquiry rather than blind administration. Filtration is both protector and potential problem. Inline filters can capture particulates, bacteria, or glass microfragments that escape detection, and they safeguard delicate organs from embolic debris. Yet for protein drugs, wrong pore size or filter material can strip active molecules from solution, starving the patient of therapy. Guidance for filter use is crafted to balance these forces, deviating without justification risks either contamination or underdelivery. When a label instructs use 0.22 micron low-protein binding filter, that hyphenated phrase is the condensed wisdom of many failed trials. pH is a fulcrum under every solution. Buffers hold it steady, but dilution can tip balance. Add a weakly basic drug to an acidic diluent and you may watch it crystallize as unionized base. Add an acidic drug to alkaline diluent and you may curve the pH into a zone where the excipients fall apart. Sometimes the safe path is to keep a solution concentrated and stable until the last moment, then dilute immediately before administration so excursions are brief. The label's permitted diluents are not interchangeable. Each was chosen because it nudged pH and ionic strength into a stable basin. Agitation means more than shaking. Even rapid injection through a small bore needle creates shear, which can denature proteins or create microbubbles that serve as nucleation sites for aggregation. Microbubbles also carry gas embolism risk if allowed to coalesce. You purge air carefully, depress plungers steadily, and respect the mechanical side of stability. A hurried push can be a chemical insult in disguise. Light protection is often literal, wrapping bags in opaque sleeves or using amber syringes, but also procedural. You minimize time spent under bright surgical lamps for photosensitive infusions. You shield pediatric lines from phototherapy units that emit blue light. You recognize that even indoor daylight by a window can drift an unstable solution from clear to tea-colored within an hour. The phrase "protect from light" is not ceremonial. The wavelength range matters, and solutions that degrade do so along predictable spectra. Waste management closes the loop. Degraded or expired drugs are not inert. Some break down into irritating or sensitizing species. Others remain potent enough to harm if scavenged. Proper disposal prevents environmental contamination and human exposure. For cytotoxic agents and hazardous pharmaceuticals, containment protects handlers from aerosols, splashes, and residues that accumulate on surfaces where they are compounded. A stable environment includes safe exits for what must leave. Documentation anchors memory. Temperature logs, reconstitution times, lot numbers, and visual check records create a chain of custody for stability. If a cluster of unexpected reactions appears, you can trace back to a batch, a fridge outage, a mixing error. Without records, signal becomes noise and learning stalls. Stability is not guesswork, it is monitored, graphed, and audited so that patterns appear early. A brief clinical moment ties these strands. A nurse prepares an infusion of a photosensitive vasodilator. The medication arrives in a clear bag, pale as water. The nurse wraps it with a light protective cover, primes the set to saturate binding sites, uses non-PVC tubing to avoid absorption, threads the line away from a phototherapy lamp, and starts the pump. Hours later, the bag is unchanged in color, the patient's blood pressure remains steady, and no unexpected alarms sound. None of this required drama, only respect for chemistry. If instead the bag had been left uncovered, the line given standard PVC, and the room lights intense, the same calculated dose might have delivered a very different effect. A second vignette. A caregiver reconstitutes a powdered antibiotic at home. They use the correct sterile water, invert gently, watch until all cake dissolves, then refrigerate as directed. On day 3, they notice the once clear liquid has a slight yellow hue and a faint precipitate at the bottom. They stop, call for professional guidance, and a replacement is arranged. The child improves without complication. Had they overlooked those subtle changes, the child might have received subpotent or irritating fluid. The difference is simply that someone knew to look. Your reflection is quiet. You realize that pharmacology is not only the headline of receptors and pathways, but also the steady footnotes of storage, mixing, tubing, and light. Molecules behave as they must. It is your handling that either honors their design or betrays it. With calm attention to environment, materials, time, and touch, you preserve what the chemist intended and what the patient needs. As you set the vial back under its amber shield, another question gathers. Even when you keep the molecule intact, how do you explain its risks and benefits to a tired, worried person so they understand and consent? And how do you choose language that calms without obscuring the truth? You imagine sitting across from someone who has just been handed a small white tablet, their eyes uncertain, their fingers hesitant. They do not see pharmacodynamics or pharmacokinetics. They see only the unknown. What will this do to me? Will it help? Will it harm? At that moment, knowledge must be translated into language that reassures without deceiving, that informs without overwhelming, and that respects the person as much as the molecule. Patient education and communication are not ornaments around pharmacology. They are part of its practice, the bridge between science and trust. The first task is clarity. You explain why the drug is given, not in abstract terms, but in words that connect to the person's experience. Instead of saying, "This is an HMG-CoA reductase inhibitor," you say, "This helps your body make less cholesterol, lowering the strain on your heart." Instead of, "This is a beta-2 adrenergic agonist," you say, "This opens your airways so you can breathe easier when asthma tightens them." Clarity means choosing terms that translate function into outcome. You do not diminish the science, you reshape it into the person's frame. The second task is honesty about benefit and risk. Every drug is a balance. You say what it is meant to do, but you also say what it may cause, gently but clearly. This medicine should ease your chest pain by relaxing your blood vessels. It may also give you a headache because those same vessels widen in your brain. That headache is uncomfortable but not dangerous. By naming side effects beforehand, you disarm their fear when they occur. Honesty builds credibility. Silence breeds mistrust when the unexpected appears. Timing matters. Information is best received in small, digestible pieces. Overloading a patient with every possible reaction, every molecular step, creates confusion and anxiety. Instead, you provide what is essential now and what can be recalled later. Written handouts, diagrams, or follow-up calls extend the conversation. The aim is not to deposit knowledge, but to foster comprehension. A person who understands enough to recall key instructions, when to take, what to avoid, when to seek help, will fare better than one flooded with encyclopedic detail at once. Tone is as important as content. A calm, steady voice conveys confidence without arrogance. Pauses allow the listener to absorb. Questions are invitations, not interruptions. When a patient asks, "Is this safe?" you do not dismiss the fear, but acknowledge it, explaining safety margins and monitoring. When a parent asks, "Why so many doses for my child?" you explain half-life and metabolism in terms of children's faster clocks. The tone tells them you are not a lecturer, but a partner. Cultural and personal context shapes how information lands. Some patients value detailed scientific explanation, others value stories or analogies. A patient from a background where natural remedies dominate may view pharmaceuticals with suspicion. Here you acknowledge that herbs and medicines both interact with the body, and that combining them without guidance can be risky. A patient whose family has seen addiction may fear opioids for pain. You explain difference between dependence, tolerance, and addiction, grounding the decision in close monitoring. Respecting context means listening as much as teaching. Visual imagery helps bridge complexity. You describe blood vessels as pipes, blockages as clogs, statins as workers scraping buildup. You describe insulin as a key opening cell doors so sugar can enter. You describe antibiotics as soldiers targeting bacteria but not viruses. These metaphors anchor invisible processes in tangible images. They are not childish simplifications but tools that allow comprehension. You ensure they remain accurate enough not to mislead, but concrete enough to stay in memory. Listening is itself education. Patients teach you their concerns, priorities, and capacity. A person struggling to pay for prescriptions may not benefit from a long lecture on mechanisms, but from guidance toward generics or assistance programs. A person juggling multiple medications may need a chart or pill box, not another explanation of pharmacology. Listening identifies barriers that science alone does not solve. Adherence emerges as the central goal of education. Drugs cannot work if not taken as prescribed. Reasons for non-adherence are many: forgetfulness, cost, side effects, disbelief, complexity. Addressing each requires tailored strategies. Reminders on phones, simplified regimens, clear labeling, reassurance about side effects, demonstration of devices all reduce the gap between prescription and practice. You transform adherence from blind obedience to informed choice by ensuring patients see the link between action and outcome. Consider a vignette. A patient is prescribed warfarin. You explain, this keeps your blood from clotting too easily. That helps prevent stroke, but it also means you may bruise more or bleed longer from cuts. That's why we check your blood levels regularly, to keep the balance safe. The patient nods, understanding both purpose and caution. Without that conversation, they might stop the drug after the first bruise, losing protection and risking harm. Education changes outcome, not by altering the drug but by guiding its use. Another vignette. A teenager with new asthma receives an inhaler. Left untrained, they may puff once into the air and believe it failed. With education, you show how to exhale fully, seal lips around the device, press and inhale slowly, hold breath, then exhale. You explain, this medicine works only if it reaches deep into your lungs. Think of it as painting the inside of a long hallway. You want the spray to coat the far end, not just the doorway. The image stays and technique improves. Here, communication is therapy. Education extends to families and caregivers. An elderly patient with mild dementia may rely on a spouse to manage medications. Teaching the spouse becomes as important as teaching the patient. A child's parent must know dosing intervals, signs of adverse reaction, and when to seek care. Communication radiates outward, recognizing that patients live in networks of support. Documentation reinforces communication. Writing down instructions, marking schedules, providing reliable resources ensures the conversation continues beyond the encounter. In emergencies, a patient may forget what was said. A card in the pocket or an app on the phone preserves the essential. Technology extends reach. Text reminders, digital pill bottles, telehealth check-ins. Education is no longer bound to the clinic, it follows the patient home. Reflection here is careful. Pharmacology is not complete until explained. Molecules cannot persuade or reassure, only people can. When you speak clearly, listen deeply, and respect context, you make the science usable. Drugs may alter physiology, but communication alters behavior, and the two together create healing. And now your mind moves to the horizon. After teaching, after prescribing, after monitoring, what remains are the questions of ethics: how to use drugs wisely, how to balance relief against risk, how to ensure fairness in access and honesty in representation. What principles guide the responsible practice of pharmacology in the wider world? You imagine a long table where many people sit, each holding a different concern. At one end sits a patient, anxious for relief. Beside them sits a physician balancing options. Across the table sits a researcher, aware of mechanisms and risks. Further down sits a policymaker guarding resources. At the far end sits society, concerned with fairness, safety, and trust. This table is where pharmacology meets ethics, where every drug decision becomes more than a molecule. It becomes a question of responsibility. The first ethical principle is beneficence, the intent to help. Every prescription is given with the goal of relieving suffering, preventing harm, or restoring function. Morphine eases pain, insulin controls glucose, antibiotics eradicate infection, yet beneficence cannot stand alone, for every drug also carries risk. Here the second principle, non-maleficence, enters, do no harm. Balancing these two creates the therapeutic ratio, where benefit outweighs risk. You prescribe aspirin to prevent clots, but only if the chance of preventing heart attack exceeds the chance of dangerous bleeding. You give chemotherapy knowing it harms rapidly dividing cells, but only if it offers hope of controlling cancer. Justice joins the table with its questions of fairness. Access to drugs is uneven across the world and even within communities. Some patients can afford the newest biologics, others cannot access even basic antibiotics. Justice demands distribution that does not favor wealth over need, that recognizes essential medicines as shared resources rather than luxuries. Global health depends not only on developing drugs but ensuring they reach those who require them, regardless of geography or income. The ethical map of pharmacology stretches beyond the laboratory and clinic to the structures of society. Autonomy is the patient's right to decide. A person must consent to therapy with knowledge of benefits and risks. This is why communication matters so deeply. Without understanding, autonomy becomes illusion. A patient may refuse opioids for pain because of personal values, or may decline chemotherapy for quality of life reasons. Respecting autonomy means honoring these choices even when they differ from professional advice, provided the decision is informed and free. Coercion, whether subtle or overt, undermines the ethical fabric of care. The principle of veracity, truth-telling, intertwines with all others. Marketing that exaggerates benefits or downplays risks violates trust. Prescribing without explaining side effects erodes the bond between patient and clinician. Truth allows patients to weigh decisions authentically. Sometimes truth requires admitting uncertainty. This drug has shown benefit in studies, but in your case we cannot predict with certainty how it will work. Honesty does not diminish authority, it deepens it by aligning expectations with reality. Confidentiality also sits at the table. A patient's use of psychiatric medication, antiretrovirals, or contraceptives may be deeply personal. Respecting privacy ensures they can accept treatment without fear of stigma or exposure. Breaching confidentiality except where safety demands, it undermines trust not only in one encounter but in the entire system. The pharmacy bag is not just paper, it is a promise of discretion. Resource allocation poses sharp dilemmas. Some drugs are scarce, whether due to cost, supply chain, or production limits. During shortages, decisions must be made. Who receives an essential antibiotic when supply cannot cover all? Ethical allocation weighs severity, likelihood of benefit, and alternatives. In pandemics, antivirals or vaccines may be rationed by urgency or vulnerability. Pharmacology here is not just science, but triage, a moral calculus carried out under pressure. Innovation brings its own ethical responsibilities. When new drugs are developed, clinical trials test safety and efficacy. Participants take risks to generate knowledge. Ethical research requires informed consent, careful monitoring, and fair selection of subjects. Trials must not exploit vulnerable populations, nor should they exclude groups without reason. The benefits of discovery should extend to those who bore the risks, ensuring that low-resource communities where trials occurred also gain access to resulting treatments. Consider a vignette. A new costly biologic emerges for rheumatoid arthritis, showing superior outcomes but at high price. A patient with advanced disease asks for it, but insurance does not cover it. The physician feels tension between beneficence, wanting to provide the best, and justice, recognizing limited resources. They explore alternatives, appeal for coverage, and discuss risks honestly. Here pharmacology collides with economics, and ethics provides the compass. Another vignette. A terminally ill patient asks for aggressive chemotherapy, though chances of benefit are minimal. The physician weighs beneficence and non-maleficence, autonomy and honesty. They explain, this treatment may cause significant side effects and is unlikely to prolong life meaningfully. We can pursue it if you wish, but we can also focus on comfort. Respecting autonomy means allowing choice but guiding it with truth. The outcome is not only about drugs but about dignity. Ethics also extends to global scale. The overuse of antibiotics in agriculture accelerates resistance, threatening future generations. Here the principle of stewardship applies, using pharmacological power responsibly so it remains effective. Stewardship balances individual benefit against collective future, guiding restraint where immediate gain could erode long-term security. Each prescription is thus part of a larger ecological equation. Education of professionals carries ethical weight too. Prescribers must remain current with evidence, resisting complacency or undue influence from marketing. When guidelines change, practice must adapt. Failing to update knowledge risks harm. Ethical practice requires humility before data, continual learning, and awareness of personal limitations. Consultation and referral are not weakness but responsibility when boundaries of expertise are reached. Reflection here is solemn. Pharmacology is not only about molecules and mechanisms but about the choices that shape their use. Every pill carries a story of intent, risk, fairness, and trust. To practice responsibly is to hold science in one hand and ethics in the other, knowing neither is complete without the other. And now the long journey nears its close. You have walked through names, classes, actions, kinetics, dynamics, choices, routes, stability, communication, and ethics. Each section has opened a new door, and beyond them lies rest. The molecules remain, the body remains, but the mind can now quiet, knowing it has traveled far and seen widely. Your breathing eases and the room grows quieter now. You have walked a long, even path. Names and classes, how drugs enter, travel, signal, and leave, how benefits and risks share a narrow bridge, how lungs open, platelets quiet, vessels relax, how timing, tolerance, and interactions shape the rhythm, how handling, communication, and ethics hold the whole practice together. You can picture the library of clear labels, the river with its gates and outlets, the harbor where molecules dock and depart, and the map on the wall where systems connect. Together these images let you organize what matters and set aside what can wait. You did not need to memorize numbers tonight. You learned structures that will catch new facts when they arrive. If later you meet a medicine you've never seen, you know to ask the same calm questions. What is it called? How does it act? When is it used? When is it unsafe? How fast does it start? How long does it stay? And what else in the body might it touch? If symptoms ever feel severe or sudden, trouble breathing, chest pressure that does not lift, confusion, fainting, you know that professional care is the next step. This session is for understanding, not for diagnosis or treatment. For now, let your attention narrow to simple things: the softness of the pillow, the gentle weight of the blanket, the steady pace of your breath. The molecules will keep their quiet laws until morning. You have placed them in order. You have earned your rest. Let your eyelids settle, let thoughts pass like distant lights on a calm road, and allow the mind to drift where it wishes, unhurried, unafraid, held by what you now understand.